The European School of Urology training that we have done across the worldwide map, and that is augmented not just by hands-on training, but also courses, webinars, podcasts, etc. Because these all make up training globally. Let's talk about lasers then. Lasers have really revolutionized. We heard a talk yesterday on lasers, Holmium and TFL laser. They work slightly differently. Holmium has a big peak power, and that helps fragment the stone. TFL is primarily a dusting laser. And when we look at the differences, initially TFL had a very good press. It goes faster and so on. It does have some advantages, but perhaps not as much as what was thought when it first came on as a new kid on the block. But it's still a very good laser. And of course, the quality of dust with TFL is much finer, so that's why it's a dusting laser, whereas Holmium is more used as a fragmenting laser, although they can both do a little bit of both. And of course, there's thulium YAG, which is a pulsed laser, and there are slight differences in all of them. I think probably it works better in stones, maybe Holmium, because of the fragmentation effect, and suction can allow the fragments to be sucked out, whereas TFL is definitely slightly better for tissue or protract ablation especially. And again, what is dusting? We talked about stone dust. I mean, you can see fragments, you can see not fully dust, and you can see dust. And that really is up to how you define it, but generally less than 250 microns is how we define as a true dust. What about temperature? Because this is something overlooked. If you use high energy or high frequency or both, you have high temperature because you have high power. And that can really cause tissue damage, especially if it's over 45 degrees. What does that mean? It can cause urethral stricture, or you can cause parenchymal damage. And that is a real problem, especially in the urethra, because that causes ureteric stricture. That is how when TFL first came in the market, you had a lot because people are going very fast, touching the mucosa and creating that heat. I'm just going to show you a video of how I do it. So for me, any stone, I start with dusting the outer layer. Then I go to pop dusting. This is a 16 millimeter stone. So initially, and this is the same whether I use a Holmium or a TFL, I will dust the outer layer using dusting setting. Once I've dusted the outer layer, the inner core usually is a little bit hard. Then I will fragment the stone. Once I have done the dusting and then fragmentation, then at the end I use pop dusting so that the stone fragments come to the laser and you can really make it much, much finer. And this is a principle I apply in almost all stones, unless some stones are really soft, where you can just keep dusting throughout the procedure. Most stones have got an outer layer where you dust, then an inner core which is a bit hard that you fragment, and then you use pop dusting to finish the job. I think if you do it this way, you can really do big stones, and we go up to 2.5 centimeter stones, sometimes pushing. You heard from Vineet earlier this morning that using fans technology now you can really push the limits, and where it is competing with mini PCNL. So here you can see I've dusted it. I'm not trying to fragment the stones, and once I've done the fragmentation as well, then we go to pop dusting, and you will see at the end it's really fine. And this technique I universally use in all the stones without any. So now I'm going to go to pop dusting, and you can see here with pop dusting the stone fragments are coming to you, and as they come to you, you just make them into really powder. Do you have to be careful with the setting? You have to be, but I mean, you still respect the threshold of 25 watt in the kidney. And you can see how it's coming to you, and what you get is fine dusting. So this is something I would recommend you to use in all. And then you can use a fans technology to remove the fragments or dust. So in the urethra, 10, 12 watts maximum. In the kidney, 25, maybe up to 30 watts maximum. How do you make sure that temperature is not a problem? By using open irrigation systems, access sheets, shorter on-off intervals, and maybe chilled irrigation in future. We don't use it currently, we use room temperature. What about lasers? It is not just about settings, there are other things as well: irrigation, handling, choice of fiber, and so on, and the type of laser. So there's a lot about lasers than just the setting itself. These are the recommended settings in the urethra, so less than, and this is from a panel expert panel consensus, and this is the recommended setting in the kidney. So you can see that most people would use less than 30 watts in the kidney. What about pressure? Pressure is something that is very, very important nowadays, because we know high pressure leads to more complications, especially sepsis, and this is the conversion of pressure, so we speak the same language. And high pressure can be avoided by using sheets in mini PCNL because of the vacuum cleaner effect. but we need better devices to monitor it. And luckily now we've got either pressure sensing wires and this is something we published using a pressure sensing wire. And when we look, 6 patients who developed urosepsis all had a pressure of over 80 millimeters of mercury. So over 80, all 6 who had urosepsis so high pressure is directly linked to high intrarenal pressure. And there is a relationship with infectious complications. This is LithoVue Elite, which is to look at pressure sensing, and we have recently used it also. And you can see the pressure sensing on the left-hand side. And as you have got the pressure monitoring. So for the first time now, we can monitor the pressure at the same time. Of course, digital technology changed the world completely because we are going to go faster, save time, and have better impact. And smaller scopes, again, has changed the goalpost again, because smaller scopes allow for better irrigation and less pre-stenting, more primary ureteroscopy, low post-op stenting, and they are there. You can just use it off the shelf. So single-use smaller scopes really have changed the way we practice. So what about single use? Where do I use a single use? Well, generally for low pulse stones which are bigger than 1 centimeter, large renal stones, hysterodiversion or urosepsis. And we have recently looked, Ali, who is also in the audience, on miniaturization and trend analysis of flexible ureteroscopes, how this has completely revolutionized the way we practice urology. What about a hybrid approach? Do we have to go single use? No, you can have a hybrid approach. And actually having a hybrid approach allows you to preserve your reusable scopes. So that's what we do. 1/3 of our cases are single use, but 2/3 we still use reusable cases. What about PCNL? We have heard a lot of talks. I won't go into detail, but PCNL has changed from standard to standard, which is less than 24, mini, ultra mini, micro, and so on. And you've just seen this, so I'm not going to go into the big detail, but the Trilogy devices or this type of devices have really, again, revolutionized because they're quicker, much better, and gets a better stone clearance rate. What about endoscopic combined? This morning we saw that. You have 2 surgeons operating at the same time, and beautifully this morning we saw how you can enhance the capability of each other. And that seems to be really working very well. And 10%, 15% of our cases we do like an endoscopic combined. What about tranexamic acid? This is something that people have tried systemically as well as through the tract. And I think you can use it. I don't routinely use it, but if there's a high risk patient on aspirin, etc., you can. But just be careful that it's not something that routinely needs to be used. But if there is a risk of bleeding, especially, you can use it either systemically through the irrigation fluid, or you can give it in the tract. What about mobile apps? This has completely, again, revolutionized mobile apps. In this huge review that we did with Ali, we had almost close to 78 mobile apps. Most were, of course, for fluid hydration, but this is going to come in a big way in the future, absolutely. What about robotic surgery? I have to say, you hear a lot, there's a lot of noise around robotic surgery for stones. I'm not sure I'm sold on to it. A, it's expensive, and B, currently there is no clear advantage, but in future, maybe it will come. What about ergonomics? I think ergonomics is very important. I sat down. If you're an endourologist wearing heavy lead gown, then unless you're built, very strong, gradually your neck, your shoulder, your back will take an effect. So I think you need to respect the ergonomics, and that is something we respect. Kidney stone surgery in pediatrics has completely changed. This is completely a new dimension. So whether it's percutaneous, ballistics, instrument size, ureteroscopy, everything about kidney stone has changed, and miniaturization has really pushed kidney stones in pediatrics. Now it's not just shockwave. A lot of kids have PCNL, mini PCNL, ureteroscopy. We do a lot for peds, and I think that really is a very good game changer for endourology. This is another case where you've got an upper tract TCC. You will see that upper tract TCC has also completely changed. You will see a tumor in the left renal side in the moiety. It is a horseshoe kidney. And initially we thought, well, maybe we need to do some open or some laparoscopic surgery. You can see the tumor. The first case when I did this same case, I used a holmium laser, and I'll show you the difference between holmium and TFL. And here we are just looking at, we have taken a biopsy, use a holmium laser. There's a little bit of ooze with the holmium laser when you use. The setting I use typically is 1 joule, 8 to 10 hertz. Then the patient came for a second look. There were some recurrences again, and I use a TFL for the second look. And you will see with the TFL, the view is maintained a lot better. There is less risk of bleeding, and it is just a little bit cleaner for the upper tract tissue. So I think in time, for us, for upper tract tumors, we always tend to use a TFL rather than homium. And you can see that you can maintain a distance. The kidney is moving slightly, you have to be careful. We generally arrange a repeat checkup in about 2 months or 3 months' time. The guidelines have just changed to 2 months now. If you're doing an endoscopic approach, ablation, you need to do a repeat in 2 months so you can have a look. So here you can see we have ablated most of it so that the most endoscopic tumor has gone. Then you book for a second look. And in the second look, of course, you have to then check again whether you've got, any other tumor cells. It should be as complete as you can. Sometimes it's not possible to fully ablate it. Then, then you can't do it. So we did another CT because sometimes we have to do repeat imaging. And you can see on the CT, we didn't see anything, but when you look closely, there are very small lesions in the urothelium. There you can see. So this was the second look, and here I'm using TFL now. And you can see TFL was just a little bit nicer. There was not much bleeding. It is a smaller lesion, but it was just nicer and more control. So I think for upper tract tumors, I think TFL really is a game changer. And again, don't go with a high frequency, go with a low frequency, energy of about 0.8 to 1, which is very similar for both homium and TFL. In the interest of time, I'm not going to move forward, but you can see how it is much more controlled. There's less ooze from the tissue. Moses, I'm not going to go into the, no, I'm not going to go into the detail of this, but you have heard a laser talk yesterday, but Moses is different. It allows the lithotripsy bubble to go that much forward, so it allows better tissue dissection if you're doing a BPH surgery. It allows better stone fragmentation if you're doing stone surgery. So I'm going to move forward in the interest of time. We have used dusting and pop dusting, as I showed you that video, and we have done over 200 patients with a decent stone size, 2.2 centimeter, mostly in the kidney. And if you look at the operative time, still under an hour. Stone-free rate, some patients have to come because they're big stones. I always warn them, you might need a second procedure. Good stone-free rate and low risk of major complications. So you can see that this, and this is without the fans. And you can see that fans already is changing this, pushing the limits forward. And when you look at Moses versus non-Moses, or a low versus high power, you can see that with high power laser, you are doing a better job in a shorter span of time, which is also an advantage. And more stone-free rate and less need for the second procedure. We have also done the 60-watt laser, which is a specific Moses laser, and that also had really good outcomes. And that is something that is a mid-power, sort of not very low and not very high like your 100-watt. And we have compared Moses versus non-Moses in a one-to-one matching. And again, Moses group had bigger stones with slightly better stone-free rate and lower complications. So again, it shows that this technological advances with pulse modulation is really helpful. What about residual fragments? It's a problem. Thankfully, with suction, we can clear them. What happens if you don't? Well, there is a good chance of disease progression, of intervention, and large fragments will cause a problem in the long run. So we should try and minimize it, and this is where fans come into nice. What about follow-up? This is from the guideline panel, and we looked at patients of 3 categories and how to follow them up. And actually, this is the follow-up protocol that we followed at 6, 12, 18 months, 24 months, and so on. This is the guideline recommendation follow-up now for stones, especially if there's residual stones. There's a lot about simulation and AI has come in a big way, and I'm quickly going to run through some AI stats. This is stone-free rate for lithotripsy, and AI is at least as good, if not better, in predicting stone-free rate with shockwave lithotripsy. What about post-ureteroscopy sepsis? And again, AI was able to predict sepsis in at least 80% of patients. And in this group, which was matched between patients with sepsis and without sepsis. You can even have a predictive model where you put the details of the patient and you can predict the chances of having sepsis in individual patients. We looked also at PCNL, and the PCNL outcomes, we looked at the large database of almost 13,000 patients, and we came up with algorithm of who are the patients and how can we predict post PCNL. So if you put the parameters, then it will give you the risk of sepsis, complications, etc., etc. This is a good use of AI in future. Also, using AI, we showed that stone volume was a better predictor of stone-free rate compared to stone size. We have used AI for flexible laparoscopy predictive tool for stone-free rate in adult patients and also in pediatric patients. So you can see how AI and predictive tool will help you individualize treatment for adults, and there are different models for AI. I won't go into the details, but there's a lot of things you can do in terms of AI, both for diagnostic accuracy, patient selection, stone analysis, and novel pathways. Radiation dose we talked about, you need to minimize it, and actually one of the ways is in carefully selected patients, you can really have low radiation. No radiation, but I would say low radiation, but you should have a backup at least in the machine. We have heard about suction. I won't go into the details and I won't show the video, but suction is here to stay. We looked at suction through the scope. This was one of the first papers looking at suction through the scope. And actually, the stone size was decent, a lot of multiple stones. And then we asked the surgeons, the suction was helpful in 95% of surgeons felt it was helpful. And again, most people, if given an opportunity, would use suction through the scope. And the results showed one minor complication, good stone-free rate for reasonably large stones. Similarly, suction through PCNL would improve outcomes, improve stone-free rate, and infectious complications. I won't go into the detail of the videos because you've already seen it. So suction through the sheath, again, you've seen the data for it. Again, really good stone-free rate. If you look at sepsis rates, 0 for nearly 400 patients. Low risk of minor complications. Good stone-free rate. If you take 2 millimeter, which is our standard acceptance, usually it's 97%. So I think suction really aims for 0 fragments, which is what it achieves. Minimal interventions, minimal complications, short procedure time, improved quality of life, and probably is cost-effective and replicable. And this is really changing the dynamics of endourology. Stone burden, we are now in the guideline panel looking at stone burden and predictive outcomes, and actually it shows that stone burden is better than stone size, and flexible laparoscopy for pediatric stones is really changed and now is being recommended as one of the first-line treatments. So how do we see as a future? I want to use the smallest scope, which is the least invasive, which dusts or have low fragments, which has suction, with temperature and pressure monitoring, with AI to predict the outcomes, and with no recurrence. This is what the future should look like. So we have the knowledge, and we now have the technology, and hope we can match it. Thank you so much, everybody. Thank you.
Ladies and gentlemen, we conclude the academic program with Session 4, Minimally Invasive Surgical Techniques for Benign Prostatic Enlargement, BPE. This session will provide in-depth insights into the latest minimally invasive procedures for the treatment of BPE. Our expert speakers will discuss the most effective techniques, share clinical experiences, and explore the latest advancements in the field.
Hello, Panos. Can you hear us? We can see you clearly. This is Bhaskar here.
Hello, Bhaskar.
We welcome you. We can hear you. We welcome you here to this session, and we are looking forward to hearing from you.
Thank you. Thank you. I would like also to thank the organizing committee for this opportunity. How I was working with my hands outside. So this is not it's a prostate approximately 65 cc's with a history of previous episodes of urinary tract infection, prostatitis, acute prostatitis. You will see the case. For the case I'm going to use, it's going to be a HOLEP case, holmium of the prostate. I'm going to use for this case the Quanta laser. This is the holmium laser that we have available at the department, 150 watts laser. It has different pulse modulation characteristics. The one that I'm going to use is the virtual basket. The settings are going to be 2 joules, 50 hertz with a virtual basket. It's not going to, I'm not going really to change to coagulation. You can also set up coagulation, in a different setting. There are 2 settings, 2 pedals to work with this laser, as with many other lasers. I'm not going to use any coagulation. I'm using the same setting. I just remain away from the tissue in order to coagulate with the same settings, the 100 watts. This is the standard setup we do have for the department. I use for this case, and usually for most of our cases of HOLEP is the instruments of Storz, Karl Storz. The Marsulator is going to be from Quanta also. This is a single-use disposable Marsulator, works quite efficiently. The technique that I follow is a standardized technique. I don't really change a lot my technique. I may pick, I have some differences regarding the strategies that I'm going to follow. For example, if I'm going to do 3-lobe, 2-lobe, or en bloc technique, smaller glands, I do them en bloc. Larger glands, I prefer to adapt to the anatomy. If I have a large middle lobe, I go for a 3-lobe technique. Otherwise, I go for a 2-lobe technique. It's standardized. I do early release at the beginning of the procedure, address the virum, release the left lobe, release then the right lobe up to the levels of 2 to 3 o'clock and 9 and 10 o'clock. And then I do a good release of the apex in order to have the adenoma completely free from the sphincter, which is, I think, the most important point is to preserve the incontinence. So let's go for the case. I would be happy to hear any questions that you may have during the case. So what you see here, we just entered to the patient. We check for the orifices. There were some small stones, some small debris. The patient had this, relatively high residual. I wouldn't say it was not more than 150 cc's. You see here, we see the sphincter. I do the early release, as I always say. I don't mind going very close to the sphincter in order to do this early release of the apical mucosa. The idea for this is that this kind of early release will help you in getting also your marks, your line, in order to avoid the sphincter. The other is I don't go very close to the sphincter because I don't really mind. It's very easy to address the field to get the different the plane of the nucleation, even though you may have done a mucosal incision closer to the lobes rather than the sphincter. It's very easy to control that during the surgery. So, as you see, this is one of my major first steps. Initially, when I started doing the enucleation, endoscopic enucleation at the department, many of the colleagues were telling me that I will have increased incontinence rates. So my main concern was always to have to respect as much as possible the anatomy and avoid having incontinence. And I would say with the technique that you see, we have very, very, very low incontinence rates after the surgery.
Panos, as you're talking, can I just ask you, for a beginner, what do you think should be the learning curve? As you mentioned, incontinence is really avoidable, but potentially you need to learn and have a learning curve. What do you think it should be for the young people here?
For the learning curve, I think the most important is to do the early release, which does 2 things. You release the mucosa, this is the one point, from the beginning, so that you don't apply a lot of stretch, you don't stretch the sphincter. And then you go to finalize the release of the apical side, which is also the anterior part of the prostate, relatively fast, as you will see in the video. So these are the 2 major points: early release, as we initially showed, and release of the anterior part of the adenoma very early at the beginning of the procedure. These are my
traction? Do you use
points.
traction? Do you use traction at the time, or do you use just energy?
I always have some tension on the tissue. There is no other way to work fast and efficiently. But as you can see, there are points that I come back, I cut, I release, and I continue to keep tension on the adenoma in order to release it. I avoid doing big stretches. You see now that I'm at the level I see. This is the final release, the anterior release that I said. I had done the cut to the mucosa. This is my guide, the initial early release that I did on the mucosa. And now I completely detached the left lobe from the apex. So the sphincter is free on that side. So I don't apply tension. This is my last cut, you see here, at the apical side. Now practically this part of the adenoma is completely released from the sphincter. So I don't apply tension. Here from this point on, I can apply as much tension as I would like.
I got it.
So, on the adenoma.
The power of the laser makes a difference. So if you have a 60 watt or 100 watt or 120 watt, because it'll cut differently.
I do, the cases that I do are either with the holmium, as you see here, with 100 watts. I do also with the TFL cases. It depends on the availability that I have at the surgery of the laser. With the TFL, I usually work at 50 watts. Does not make a big difference regarding the the enucleation rate, or to do this kind of preparation does not make a big difference, the laser or the power that you may use. What I have noticed is that I'm a little bit slower using the TFL. When I mean a little bit slower, it's something like 5-6 minutes, 8 minutes will take me longer to do the enucleation, depending on the size, of course, of the prostate, when I use the TFL. So the power, the high power, does not make much of a difference, I suppose, because I haven't tried that. If you have a very low power laser, like a 35 watts, that would be a lot of trouble to do.
And what about hemostasis? Does it make a difference between TFL with holmium?
I feel that the TFL is a little bit more hemostatic. And if we had, I could prepare, I have done it before, a video showing what are the differences when you do similar glands between TFL and holmium. You will see that the holmium is quite hemostatic, but how you are going to handle the different vessels, it's completely different. With the holmium, you can fire on the vessel, but if you have a bigger bleeder, usually you manage to control the vessel by firing around of the bleeder. The higher bubble, the higher mechanical effect that the laser has will end up, punching a hole on the big vessel if you use the holmium exactly on the vessel. When you use the TFL, you can do that directly on the vessel, and you have hemostasis. It's a little bit more hemostatic, the TFL. In the final, results to the patients, the clinical outcome, I think it remains the same. There is no difference among these two lasers. Whatever you have in your disposal is going to be just fine for you to work with endoscopic enucleation if you are interested to do that. And also is an excellent procedure. You see, now I release completely the anterior part of the other lobe, of the right lobe. I take advantage of the initial early release markings that I had in order to know exactly where I'm going to work. So I'm going to completely here release the anterior part of the adenoma. Of course, there are different techniques in how you are going to release the adenoma. I would propose to the people that they want to start now to do enucleations of the prostate, not to go for an en bloc technique. You will need some more experience in order to be very efficient in following the field and finding your way with the en bloc technique.
So
I would suggest,
Panos, you would recommend for beginners to do a 3-lobe technique rather than en bloc?
3-lobe technique at the beginning, yes. 3-lobe to 2-lobe technique, because you want to release some of the adenoma to have more space and move around.
Panos, question from Azim John in the audience.
Yeah.
Hello, Panos. Thank you for being together with us.
Hello, Azim.
Very nice technique. So can you comment your borderline to choose between 2RP and the HOLEP, I mean the size of the prostate? Which
I
size
can
is
tell you that
acceptable for HOLEP?
I don't super small prostate.
For any size?
I mean, 25, 30.
Panos, sorry, this, I'm, go-
I will do an enucleation technique.
this is, I'm going to, you're killing us, huh? I mean, why would you not do a TRP for slightly, like this, and I'm sure you have your reasons, but why not a TRP for some of the prostates?
It does not make much of a difference. You could do it to your case. But from, because you just asked me what is the smaller, the
Okay.
smaller size. Yes, in the past I was doing a 40 and higher. Whatever was 40 and higher, I would do it enucleation. Now even the 30, I would do it. Just you're not going to have a big adenoma, but you're going to have a slice, big slice of the inside of the prostate, just completely released, and the capsule is
Is it
there.
more difficult? Because
Of
when
course,
you
you
have,
can do the URP. It's a matter of personal preference.
no, I
Does not make
understand.
any
Yeah, yeah.
difference in that small sizes to do a HOLEP. What makes the difference is when you increase the size.
Does it
Yes,
make,
Pascal?
does it make it more difficult for the 30 or the 40 cc to do a HOLEP?
It is. It is. I think it would be for the beginners. It would be a lot easier for them
So what is the
to,
ideal
to do the
size?
URP in such small prostates.
What is
The
the ideal
extremes,
size?
either
Ideal size
what
for
is
beginners. Ideal size for beginners. Let's say,
I would say that it's 50 to 80 cc's. That's it.
okay. Yes,
This
please.
would be the size that is more easily manageable and for them, and will be easier to start with enucleation. I wouldn't go for the always the extremes of what you do is going to be the more troublesome. Either you do the very small glands or the very big glands. You are going to have trouble in these kind of cases if you are a beginner. You need some experience to do that. As I said, the 30, 40 cc's glands are more difficult to do at the beginning. I would suggest that you do it to URP, of course. It's going to be just fine with the TURP. From a point on, when you are used to doing, the enucleations, you don't mind. You are not going to switch your instruments, whatever, to do something differently. That's why I do it. It's a personal preference. For big prostates, for example, my limit usually is up to 220, 200, 250, depends. I don't want to do very big glands because I think it takes too long. It takes too long. Why? Because you have to enucleate a big gland. It takes some time to do that. Takes a lot more time to do the marcellation, depending also with the marcellator that you have in your hands. So for me, that I'm quite experienced in doing lap adenomectomies or robotic adenomectomies, it's a lot more faster and efficient to do a laparoscopic adenomectomy in a 250 or 300 cc
Panos,
prostate
there's a
than doing
question
an
from
enucleation
Lorian
endoscopy.
in the
Please.
audience. And after that, I want to know your preferred modulator. But first, Lorian will ask a question.
Hi, Panos. Good to see you, my friend. Very, I'm good. Very, very nice procedure. I love it. I love your technique. About the prostate volume, there is that sweet spot or sweet size for prostates. It's 60 cc. That works for everything. The prostate that is good for every procedure is also the prostate that is good to do HOLEP, to start HOLEP with. Now, just a quick question about, because I know you're very good with holmium, but also with thulium fiber. Do you have any subtle difference in terms of the tension that you apply on the tissue, holmium versus TFL? Do you feel like you need to put a bit more or a bit less pressure?
I always apply some gentle tension on the tissue. Always you need some tension when you do surgery, regardless of what kind of surgery you do. It's the same on this.
Perfect. So you don't change. You don't change at all the pressure with TFL versus holmium. No.
What are the differences? Minor differences now. You must get quite a lot of experience involved in order to understand these minor differences. The one is that when you use the TFL, you can cut easier through the tissue. So sometimes you can go through a specific plane if you have a difficulty, and cut through it using the TFL. The other is when you use the TFL, you need your fiber to be a little bit closer. Imagine that with the TFL you never have this big bubble that you breaks the adhesion between the adenoma and the capsule. So with the TFL, you need your laser to be a little bit closer to the tissue. So you have, when you use the TFL, you have a fiber closer to the tissue, and you take advantage of that fiber also to cut a bit through the tissue. When you use the holmium, you always have the tension, and you rely on the efficacy of the higher peak power and the bigger bubble, the bigger mechanical effect that has to break the adhesion. Okay. This is, I think, minor changes, minor differences that, if you use the one or the other, if you use both, you can understand them. Otherwise, it does not really matter, for the clinical practice or for the patient.
And your choice of modulator, Panos, which is, so if somebody had to start, which is a modulator you would recommend?
Okay, I haven't used all possible marcellators. I haven't used them. But from those that I have used them, I would recommend the Jena surgical marcellator, which is excellent. It's the one that I have and works very, very fast, very efficient marcellator. I also have the Karlstorff marcellator, which is also very efficient. Not at the same level, but does not, if you know to use them properly, it's not a big problem. Of course, any other marcellators that I haven't really used them in several cases, I cannot really tell you, my thoughts about it. There are different others. I have seen videos, I have talked with colleagues, but I cannot specifically recommend something that I don't use, routinely. I have done several cases.
Yeah. Laser fiber, what size do you normally recommend?
Usually I use the 550. Of course, you can do it with a smaller fiber if you want to. You can use it with a bigger fiber, but I think 550 is the sweet spot. You have a stable enough fiber, and at the same time, it's, it goes nicely through your sheath, the small, opening the small sheath that the Kunz element has.
And any tips or tricks with big prostates? You said, you have your personal limit, but let's say you had a big prostate, 200 cc. What is the difference with the big prostates? How do you maintain your anatomy?
I would go for a 3-lobe technique most likely, or a 2-lobe technique, probably 3-lobe technique. Starting at the middle lobe, as usual, it's very important to understand that when you do endoscopic enucleations of the prostate, it's not like the TURP. If you start with the TURP, and from a point on you have bleeding, something goes wrong, you can make a nice channel, the patient will urinate, everything can go well. The problem with enucleation is that you have, whatever you started enucleating, you have to be over with it. So by starting with several different lobes, by starting with the middle lobe, it's highly likely if you have any trouble, if you cannot see, if you cannot continue working, you lost your way. If you enucleate the middle lobe, you can expect a patient that will urinate. If you go to the left lobe, and that works also for you, and you removed it, by leaving a right lobe only there, if it takes too long for you, especially at the beginning, which is, your efficiency is lower, the patient with a mid lobe and a left lobe removed urinates fine. You always try to be very careful with the plane, which is something that is in all prostates, but especially the larger ones is even more important. Because if you lose the plane in the large one, you don't have so freedom of movement. You may have more bleeding. Address big bleeders during your way, because it will take long, your surgery.
Panos,
and if you have one bleeder there, yes?
Panos, you've got
please?
5 minutes, but I've got a question from Professor Martov. But we finish in 5 minutes. But excellent demonstration so far.
Yep. It is okay. You see here that we have already enucleated the adenoma. We did the block technique. What I'm going to do, I was just finding here the last, adhesions. Here you see my fiber is on the lower side. I worked most of the case with the fiber at 12 o'clock. Here I work at 6 o'clock when I get to the level of the bladder neck. Because if you imagine how the fiber fires, it's easier to get the orifices if you have it at 12 o'clock. So I get it when I'm at the level of the bladder neck, I get at 6 o'clock. Now, what I do is what I told you. With the same settings, I stay away from the capsule, and I just use any coagulative effect that the laser has in order to do some hemostasis. I do go specifically to the larger bleeders and around them in order to provide some hemostasis. You see how nicely
change the setting?
it works.
It's going really well, but do you change the power setting at all?
No, at all. No, at all. I don't think there is any significance on this. If you get, it's not for the beginner. I would suggest that you have a coagulative setting. But for me, I stay with my fiber further out from the capsule so that you don't have the mechanical effect opening up the capsule. You just want the coagulative effect of the laser. You see how it works. The main reason why I do this hemostasis is that sometimes if it bleeds quite a lot, I even get the transurethral instrument in there and I do a nice coagulation of the prostatic fossa. Why is that? Not because it's going to bleed after that if you place a catheter. I do that because you need to see very well during the marcellation so that you don't injure the bladder. This step is very important for the marcellation. You have to prepare your field. You have to do good coagulation so that you have as clear as possible field in order to do the marcellation. I think the worst part of the endoscopic enucleation is the marcellation, is where you can do most of the damages by marcellating the blood.
One question for you. Do
Yes.
you use elective surgery after laser enucleation or not?
This is what I just said, that if I don't have a clear field to do the marcellation, I will go in with the electric energy, with the bipolar, for example, or the monopolar, to coagulate the bed so that I reduce any bleeding and be able to see nicely during the marcellation. It's a very important step.
How often do you need to do that, Panos? Let's say.
It's not very often. Maybe it's 1 out of 10 cases. It's not very often. You see here. Yes?
What do you think about Rezum? Alternative option to HOLEP?
It's not an alternative option to HOLEP. Rezum is very specific. What sizes of prostate it can take care and what will be the final outcomes for the patient. I also do Rezum, but I do it, in very specific cases. I do smaller glands in patients that they are very, very, they want to have to preserve the ejaculation. And I explain them that the recurrence of the problem could happen very fast within the first 2 or 3 years. It's highly likely. And also 2 out of 3 patients will have reduction in their symptoms, but 1 out of 3 will not be that lucky. I have done many cases after Rezum as an enucleation. I mean, not only my cases, but you have to, in order to, for each technique, you have to, to get the correct, to select properly the patients. It's not a matter of debate, do Rezum to everybody, do HOLEP to everybody. You have to adapt. But the Rezum for sure is not an alternative to HOLEP. It's a completely different, the outcome is a completely different, in a completely different level of HOLEP.
You've started marcellation. The procedure has gone very well. Thank you so much for an excellent demonstration. Can we have a round of applause for Panos, please? Thank you so much, Panos.
Thank you. Have a good time and
Thank you. Thank you. Thank you very much for excellent presentation. Thank you. Я хочу прокомментировать буквально полминуты по поводу того, что говорил оперирующий уролог. Ну, на сегодняшний день современный TFL абсолютно воспроизводит все гольмиевые вещи, несмотря на то, что гольмиевая энуклеация остается золотым стандартом в энуклеации. Современные тулевые лазеры уже полностью воспроизводят все гольмиевые параметры и большие пузыри, и вы можете выбрать и вапоэнуклеацию, и гольмиевую бесконтактную, и контактную, и резекцию, и так далее. Поэтому от того, что сегодня нам дает технология, конечно же, эта операция во многом преуспела и, в общем-то, занимает основную часть сейчас всей хирургии доброкачественной гиплазии предстательной железы. Поэтому марцелляторы основные на рынке, вы знаете, Пирания, Шторц, Люминис И новые есть компании сейчас китайские, которые также воспроизводят очень хорошие марцеляторы. И скорость увеличилась в 3-5 раз марцеляции, чем это было когда-то. Спасибо большое. Мы переходим к следующей презентации. У нас как раз энуклеация простаты с помощью тулевого волоконного лазера. Тулеп. Фурхат Насиров, пожалуйста.
Добрый день, коллеги. Сейчас поговорим, какая функция, как работает тулевый лазер при кровавых, как говорится, кровянистых аденомах. Когда вот приходит больной, мы заходим на операцию и видим аденома, она отечная, кровоснабженная, и периодически приходит больной с кровотечением. Вот этих больных, когда заходим и смотрим и думаешь, каким методом это делать, каким лазером. Если под рукой имеется гольмий лазер и тулевый лазер, я считаю, что надо тулевым лазером работать, потому что у нас в клинике это никакого у меня конфликта интересов нет. У нас и гольмий лазер есть, и тулевый лазер есть. Поэтому есть возможность, где можно определиться. В таких ситуациях, когда такие больные с кровотечением поступают, она эффективна. Ага. Вот, кстати, 2 недели тому назад поступил больной, 72 года ему, с жалобами затрудненного мочеиспускания, частыми малыми порциями, с чувством остаточной мочи и с макрогематурией, периодически возникающей макрогематурией. В таких ситуациях, вот, когда мы зашли, увидели вот такую картину. Такое отечная аденома. При обследовании обнаружили остаточной мочи 60 мл, максимальный поток мочи 10 мл в секунду, и аденома размером 150 грамм и переходная 125. Вот решили сделать тулевым лазером. Тулевый лазер ЯК. Обычной методикой по гиллингу сделали вот подкообразный разрез. И я решил сделать его единым блоком, с последующим его разделить, потому что большая аденома, более-менее. Чтобы вокруг него легко обходить, решил сделать единым блоком, N-блоком, и разделить его на 2 части в конце, когда уже переходим на 12 часах, уже заходим в шейку мочевого пузыря, вот тогда я разделил его на 2 части. Лазер, ЯК-лазер, тулевый, 67 ватт, 1,7 джоуль, 40 Гц. ЯК-лазер, кванта.
Тулевый ЯК-лазер здесь у вас.
Тулевый ЯК-лазер, кванта, 150 ваттный агрегат. И вот такая у него великолепная вапоризицирующий у него эффект, как видите. Конечно, кто занимается гольмиевым лазером, у кого опыт гольмиевым лазером, они говорят, вот такая карбонизация, можно в больших аденомах запутаться. Никак здесь не запутаешься, потому что отличная гемостатика, и если план правильно планировать технику и вообще операцию при больших аденомах, нигде никак не можешь запутаться, потому что если раннюю диссекцию сделать, отойти от сфинктерного аппарата и по периметру, по окружности одновременно диссекцию проводить, по-моему, легче, никак не ошибешься, никак не запутаешься. Конечно, трехдолевая техника рекомендуется для начинающих хирургов. Трехдолевая, она наоборот, я считаю, что можно запутаться немножко. Потому что можно сфинктерным аппаратом не разобраться. А здесь вот ранней диссекции единым блоком, когда идешь, вокруг можно отойти от сфинктерного аппарата, а там уже можно, в принципе, можно и трехдолевую, двухдолевую сделать. Вот. И я думаю, что ранняя диссекция, она играет огромное значение. И вообще мои коллеги, и европейские, и российские, мои друзья, мы с ним советуемся, и у них намного тоже мнение на этом, что ранняя диссекция – это очень удобно для… От осложнения можно отойти. Самое страшное осложнение, конечно, каждого, кто занимается инокуляцией ДГП, это боятся все от недержания мочи. Вот. Как видите, вот правую долю мы сейчас на раннюю диссекцию на 12 часах проводим, правую сторону. Вот. Выделили, вот коагуляция какая. Быстрая коагуляция, хорошо идет диссекция, она можно… Конечно, для начинающих всем надо учиться вхождение в слой, все равно механическое выделение, она присутствует как гольмиевым, так и тулевым, так и электро, то есть биполярная электроинокуляция. Надо хорошо уметь входить в слой и научиться трансурethральной, после учебы трансурethральной, владеющей трансурethральной резекцией и биполярной инокуляцией, легко, я думаю, что заниматься и тулевым, и гольмиевым лазерной инокуляцией. Не зная, конечно, я считаю, что механическую инокуляцию, я думаю, что нельзя заниматься лазерной технологией, потому что лазерная технология, техника, она очень интересна, она может быть в любое время технически какие-то неполадки будут, надо уметь переходить на электроинокуляцию или трансурethральную резекцию. Как видите, очень вапоризация и резекция очень хорошо идет на этом тулевом як-лазере. Видите, как он. И при больших аденомах я делаю по 2 ряда делаю резекцию вот, или диссекцию, чтобы тубус резектоскопа 26 он свободно потом проходил по этой дорожке, которую мы открывали. Для больших аденом. Это уже на 12 часах вот встретились в зоне диссекции.
Но, вы видите, совсем другая техника, совсем другой лазер, совсем другие возможности лазера.
Ну да, видите, как
совсем
она
другая
идет.
техника.
Конечно, быстрее она идет, работа. Ну, здесь немножко увеличили, чтобы время сэкономить.
Для бесконтактной гольмиевой инокуляции нужно большое терпение. Не все обладают, это действительно так.
Да, кто вообще начинает заниматься инокуляцией, надо большое терпение иметь. Потому что вначале, конечно, это долго, не сразу получается. Это надо сидеть и хорошим интубационным общим наркозом надо делать, начинать эти. Ну, мы под спинальной анестезией делаем, уже когда уже опыт набрали. А когда вот начинающим, надо под общим наркозом спокойно работать и учиться. Ну, конечно, предыдущие эксперты, учителя говорили, обязательно надо быть, чтобы рядом был учитель, хороший наставник. Сам по себе начинать, это, конечно, опасно. Мы сейчас вот левую долю выделяем на 5 часах, подходим к шейке. Ну, как вапоризекция, она очень бескровно идет. Аденома, между прочим, очень кровянистый, очень кровоснабженный орган. Был вот в данном ситуации. 2 недели тому назад оперировали его.
А какие параметры, вы не помните?
Параметры 1,7 джоуль. 1,7 джоуль, 40 герц, это 67 ватт. Да, иногда, как и друзья говорят, наставники говорят, что надо области сфинктера надо до 30, до 40 ватт надо снижать. Но я не видел осложнений. Вот она, сфинктер у нас образовавшийся, вот оставшийся. Вот. Все нормально. Но я сторонник тоже коагулировать. Но в данной ситуации обязательно надо было коагулировать, потому что сосудов очень много было, чтобы спокойно было вечером, чтобы не вызывали. Люблю вот этот вот инокуляционный кубик-шарик. Вот на нем коагулируем.
Вы всегда после лазерной инокуляции проводите электрохирургическую ревизию?
Я всегда. Всегда. Ну, спокойнее будет. Там, ну что, одним тубусом поменять на активный элемент или на шарик перейти, это не проблема. Это вот как и в Шторц, как и Олимпусе инструментах, никаких проблем нет перехода.
Ну, вообще вы работаете в богатой клинике. Вы используете специальную нуклеирующую петлю компании Карл Шторц для коагуляции.
Очень
это
дорогая,
круто.
Да?
Это круто.
Вот. А марселяцию мы начинали с шторцовский марселятор, но немножко роликовый отсос, она немножко слабовата, мне кажется. Но это мое мнение, чисто как эксперт. А вот в настоящее время мы занимаемся сейчас марселятором. У меня и пираньи есть, и вот на сегодняшний день и хёк получили китайского производства. Очень хороший, эффективный марселятор. Я думаю, что конкурирует с пираньей, с вольфом. Вот сейчас я остановился для чего? Чтобы наполнился мочевой пузырь, чтобы безопасно было. Периодически останавливался, заполнял. Потому что одним шлангом работал.
Да, основные правила марселяции остаются всегда неизменными. Первое – хорошая видимость. Второе – полный мочевой пузырь. Третье – работать в центре мочевого пузыря. Это 3 основных правила марселяции. Любой, при любом способе энуклеации, электрохирургической или механической, лазерной, такой, сякой. Это основные правила марселяции. Сперва хорошая видимость, потом полный мочевой пузырь и работать в центре мочевого пузыря. Многие для этого принимают второй канал для поступления жидкости. Ну и, естественно, сочетание сакшена марселятора и наполнителя мочевого пузыря. Это очень важно, потому что если вы не будете регулировать аспирацию на марселяторе, то будет пустой мочевой пузырь, и это опасно травмой стенки мочевого пузыря, потому что марселятор очень хорошо жует аденоматозную ткань, также очень любит жевать и стенку мочевого пузыря. Имейте это в виду. Какие-то еще комментарии? Any questions? Какие-нибудь вопросы? Пожалуйста. Давайте.
Спасибо большое. Вот мы работаем гольмиевым лазером, и часто вот хвалят толевые лазеры, ну, руки чешутся, хочется купить, но думаю, шкурка выделки стоит или не стоит. Мне вот на всех видео, да, мне кажется, все-таки у толевого лазера, вот когда вы тоже делали, больше механическая вот инокуляция, да, тулевую как будто режете, а вот с тубусом вы помогаете, не так ли? Вот первый вопрос. И второе, насчет, был ли у вас опыт недержания мочи, тотального недержания мочи, когда нужно устанавливать вот сфинктер искусственный? Вот, например, я больше 1000 штук сделал, мне 2 штуки, и эти пациенты мне, ну, кошмар моей жизни, скажем так.
Спасибо за вопрос. Тулевый лазер, да, есть методика, конечно, механически выделять можно, и можно сделать вапорезекцию. Почему не делать вапорезекцию, если стесняться от этого, когда мы делаем трансуртральную резекцию, тоже резекцию. Ну, конечно, результат одинаковый. Тулевые лазеры, да. Тулевые лазеры есть сейчас на сегодняшний день, вот последний вот У3, вы, наверное, в курсе, У4 и У5. У них там функции и камни дробить есть. И есть функции, которые можно как гольмий лазер есть. Например, там 4 джоуль, 15 или 10 поставить герц, он работает как гольмий лазер. Можете купить тулевый лазер, оно будет как работать и гольмий лазер. Хотите, механически можете работать или вапорезекцию сделать. Вапорезекция, она бескровная вообще будет. Это научиться надо просто. Все боятся вапорезекции. Это же резекция, говорят.
Фуркат, я хочу пояснить. Эта операция производилась тулевым твердотельным лазером, непрерывным лазером,
Да.
приспособленным только для лечения мягких тканей. Тулевый волоконный лазер – это совсем другая история. Абсолютно другая история. И современные тулевые волоконные лазеры вы можете работать бесконтактно с теми же пузырями, как у гольмия. Вы можете работать контактно, вы можете его паривать, вы можете резицировать и так далее. Это 2 разных лазера. У Фурката был лазер совсем тулевый,
Непрерывно.
твердотельный, приспособленный для работы только на мягких тканях. Поэтому это 2 разные концепции, 2 разные позиции. Еще вопросы?
Маленький просто комментарий. Спасибо большое за видео, очень показательно. Я как раз хотел сказать, что у нас в клинике стоит, и я так понимаю, вы работаете на Сайбере 200 ватт. Правильно я понял?
Кванта.
Кванта, Сайбер.
Сайбер.
Лазер называется Сайбер. Сайбер – это твердотельный лазер в 200 ватт. Мне показалось, что вы работаете на максимальной мощности и очень выраженный эффект карбонизации. Я могу сказать, что мы работаем, делаем инуклеации и вапорезекции. Вапорезекции сейчас практически не делаем, но, как правильно сказал коллега, не получается вот на этом, согласитесь вы или нет, в чистом виде лазерная нуклеация. То есть это, по сути, получается, как я согласен, механическая нуклеация, чтобы быть в слою, и надсечение каких-то вот шварты соединений, когда это потребуется. Потому что в чистом виде мы в слой с этим лазером не можем войти, потому что идет очень выраженная карбонизация, он режет, у него очень глубокий рез, и происходит такое взлохмачивание тканей. С другой стороны, у этого лазера вот из преимуществ, в моем понимании, это то, что если мы где-то как-то вот зарылись, извините за простое слово, и не можем, вот при гольмиевой инуклеации, бывает, мы просто в ткани настолько взлохмочены, что мы просто не можем найти, куда идти. А здесь вот мы можем как торпедой, Алексей Георгиевич, вот так вот пройтись. Мы знаем, что там полость мочевого пузыря, и выйти туда.
Ну,
и
как
это,
у один.
Да, тараном таким.
Молокольник.
И я хотел бы сказать, он неоднократно нас выручал, когда у нас были проблемы с марцелятором. Это очень такая хорошая опция, и быстро это получается на этом лазере. Когда мы делаем по типу гриба, но не стуриваем, а просто разрезаем, рассекаем всю аденому на несколько частей, которые можно вымыть. Это очень здорово, поэтому вот это одно из таких значимых преимуществ
Еще
лазера.
у нас есть минуточка для
Спасибо.
аудитории, у меня вопрос. Вы все говорите карбонизация. А вам не кажется, что это больше фетиш такой? Ну, карбонизация.
Да.
Мы когда-то начинали электровапоризацию компании Карл Шторц, так у нас там не просто была карбонизация, а такая карбонизация, что и ничего, вы думаете, была больше дизури? Не было. И сейчас вот карбонизация, если это мешает войти в слой при анатомической нуклеации, при гольмии, это имеет значение. Если вы делаете вапорезекцию, ну какое значение имеет? Китайцы вообще там, за 20 минут ее просто вот кусками нарезают, выкидывают. Функциональный результат, поверьте, абсолютно такой. Больше дизури? Нет больше дизури. Ну, карбонизация, ну не очень красиво. Но в конце операции, если мы сейчас показали бы, там уже этой карбонизации нет, она вся смылась уже. Поэтому просто
здесь, конечно, от техники зависит, конечно, хирурга. Но здесь я быстро работал, большая аденома была, мне надо было заканчивать, он кровотечением пришел больной. И надо было уже всю эту резекцию закончить по времени. Там где-то 1,5 часа работали. Там окравлено, да, все это коагулировали, проходить надо было. Это коагуляция очень хорошо прошло. Дело в том, что можно было, конечно, сделать, как вы говорите, без карбонизации. Небольшим механическим подталкиванием увидим, по краю идем. Мы не делаем такую резекцию, как говорим, вот Китай, вот так вот большую резекцию сделали, и все. Здесь мы видим стенку, аденому, что отошел, и капсулу. Подталкиваем, да, ориентир, и пошел. И вот тем режимом можно было работать, конечно, о котором мы говорили. Гольмиевый режим есть, но не в этом аппарате, конечно, есть другой аппарат. Файбер, весь этот. Вот на этом импульсивном режиме можно работать без карбонизации, как гольмиевый лазер выделяет он хорошо. И, конечно, слишком близко я подходил, резекцию делал, можно было на расстоянии небольшим движением, можно было расслоить его и закончить это дело. Это я думаю, что до 120-100 граммовых аденом очень прекрасно получается без карбонизации. Это от хирурга и по времени зависит, кто как работает, кто привык.
Thank you so much.
Недержание у меня у одного больного, это начинал лет 7 тому назад, первые больные были, 150 граммового аденома, молодой, без наставника, и начал я тогда. У меня тоже было, конечно, у него тотальное недержание мочи. Через год пришел, у него не полное недержание. Он недавно, когда стрессово остался, конечно, когда смеется, когда двигается, у него Все равно. Он не пошел никуда, не лечился, но он довольный был, никогда у меня кровь не пил.
Вы, наверное, Фуркат, вы, наверное, все знаете
Хороший больной попался мне.
такую американскую урологиню Эми Крамберг, да? Кто занимается энукуляцией, наверняка видели ее видеофильмы. Она не занимается работой по раннему высвобождению сфинктера. Не занимается. Почти у всех пациентов на 2-3 месяца стрессовое недержание мочи. И это считается нормой. Через 2 месяца все проходит.
Через 3 месяца.
Через 2 месяца все проходит. Поэтому от техники очень много зависит. Мы сегодня все почти, и я уверен, сейчас у Драгуш тоже будет раннее высвобождение сфинктера, все остальное потом.
Thank you so much. I think we are running late. That was very good. Thank you. We call the next speaker now. Can we have a round of applause, please? And Florian will come back.
Florian Dragoš, please.
Thank you, Professor Nasirov. Very nice example. I love the technique and all the explanation, but mostly I love the fact that you emphasize that this procedure, it's good to have a mentor. It's good to have someone who's experienced and shows you how to do it. So what I'm going to show is the pulsed thulium YAG laser, and I do agree, I would like to feel at least that I'm doing my best to prevent incontinence. So what I'll show you here, it's going to be just a summary of a procedure. So I put the scope on the Veru, I check the sphincter behind me, then I lift the scope and I make the 12 o'clock incision, and then you see I retract the scope. It is good for everyone to understand where the sphincter is, and when you see that sphincter, that is my incision. So I am away from the sphincter all the time. It's quite good to understand what are the principles and what do you want to avoid, where you start, where you end. And I do the same thing on the other side. Again, you'll see I'll come back a bit. This is the sphincter. I know I'm safe. I go downwards. I do this almost every time. We always have fellows with us, and I have to show them. I have to come back and show them and teach them and make sure that they understand what's going on and they understand what are the landmarks, how they can actually do it as safe as possible.
Is this thulium YAG?
Sorry?
Is this thulium YAG?
This is pulsed thulium YAG.
Pulsed thulium
YAG. Yeah.
New Dornier machine.
It is the Tullio machine.
Tullio.
Dornier.
Dornier.
Yeah.
New one. Okay.
So you remember my talk about thulium, about pulsed thulium, so holmium, thulium fiber, pulsed thulium. You see there's almost no carbonization with this machine. So it's again a very good compromise. It has the amazing coagulating abilities of thulium, and also blasts and splits the tissue and doesn't char the tissue as holmium. So a compromise in between two. Now you see also, very nice, very important, and I fully agree with Panos. I want to detach the apex as soon as possible. And I also, once I've done the so-called wine line, the landmark there, that is, I also deepen it. I don't stay just in the mucosal plane, and I detach this part apically as soon as possible. So I'll put as less traction on the sphincter as possible, and then you can go around and do it nicely. That's not an issue anymore. Basically, most of my video is focused on this part. So this is a kind of an en bloc technique, but I'll show you what the difference is. I just wanted to present things in a way and something that is probably not so common even with en bloc. I'll show you a bit later. But for the moment, this is it. And you see the same thing on this side. You see my incision, my early apical mucosal incision is a bit deeper. It's not just the mucosa. I want to cut through the first muscular layers. And now I lift. And then again, once you lift a bit, you go and cut above so you don't put too much pressure on the sphincter laterally. Okay? You detach and then you cut this area above to avoid putting pressure behind you. The sphincter is behind you. For the beginners, you also need to understand something. And it's a very nice example. You see it quite soon. Again, your initial incision was a straight line. But now this line, the vertical line, gets horizontal as you push the adenoma. So when you cut, The red part above is basically your vertical incision that got horizontal, and you just cut under it, and you are in the safe plane, in the safe space. Because a lot of my fellows were asking, okay, but I've cut it like this, where is it now? Where am I? So what you did, you pushed the adenoma, and the horizontal line went up, of the vertical line went up and got horizontalized. And you know that you cut under it, and you put the tip of the scope upwards and start cutting the bridge on top of it, and then you get into there. So I said it's a different, it's an end block, but with a 6 o'clock incision. Why? This was a very high bladder neck. And I also wanted to show safe, safe, safe. Safe means try to avoid pitfalls. What can happen when you do a full end block with a high bladder neck? You may end up getting too much into the bladder and reaching behind or getting very close to the ureteric orifices. But if you make the 6 o'clock incision, it allows you to control the lower part of the bladder neck quite nicely, and you can just enucleate the prostate in a single piece. So it is still end block, but you control the bladder neck area. And I think I'm only showing one lobe in this, but you probably at some point you'll see how good is with coagulating this laser. Look there. It literally takes, a few seconds, and you can control a bleeding vessel. I think I've said more or less most of the things that I wanted to emphasize during the procedure. So if you have any questions at this stage, feel free to ask. Otherwise, I hope my video is not too long. I've skipped the other lobe, I think. I just kept one lobe. So you see, bladder neck, I get to the level of the bladder. So they ask me, how deep do you cut? You cut until you basically see the mucosa of the bladder more or less in line with your scope. This is your level with high bladder neck. And then you start to peel it off laterally from the bladder neck onwards. But always remember, the bladder neck is like this. When you peel here up. When you go down, it goes down abruptly, and then it goes up again. So understanding the anatomy of the prostate is crucial. Your scope is never in the same plane, is never going only up or only lateral. So that is the beauty of HOLEP. You need to understand what you do, like with every operation, but you also need to understand that the pressure, it's not always the same, because the plane is never a straight line, okay? And also, this is a plane surgery. If you do a HOLEP, an enucleation, not an enuclear resection, everyone says and everyone understands and knows the most important thing is the plane. And you may lose it. I'm pretty sure you lose it. Look, you see how nicely it coagulates. I'm pretty sure you lose it. I lose it. I lose it even now many times. The thing is, understand where is your start point, where is your end point, and try to unite them. You may cut a bit to the prostate, but you will find the plane again. If you lose it, go back to where you lost it, and then try to identify where it goes. As long as you stay right in the plane, things are going to be okay, and the control of bleeding will be quite good. If you need to control bleeding vessels in the adenoma that you've cut, then it gets a bit more tricky. This goes towards the bladder neck. I did cut a lot of the procedure itself. It was just basically to show you that, any laser you can enucleate with any laser, as Professor Nasirov very, very nicely showed. Again, the coagulation abilities, really impressive, isn't it? So it goes quite well, it works well. Understanding what you're doing is key. Respecting a few principles is also important. Trying to really detach, not just in size, really detach. You saw what I did. As soon as I was able to, I was detaching fully the lobe from the apex, from the area that is close to the sphincter. Okay, even a more strong bleeder, you can really control it. Good. Questions or comments? As I said, it's not the whole procedure here. It's just basically a few things to understand. Corners are also important. So this is good because I just wanted to show how you lift up from the bladder neck onwards. You have the upper incision already done, the bladder neck incision, and you really control the bladder neck. You really control. Look, the UO is far away in front of me. I'm completely safe. I'm safe behind me. I'm safe in front of me. The only thing that remains to be safe is lateral, isn't it? And it's the corner. So how do you deal with corners? You don't try to go on it. You go posterior, you go lateral, you go posterior, you go lateral, and then your corner gets thinner and thinner and thinner, and then you can lift it if you want. If it goes nicely, that's fine.
Lorian, what is impressive is the hemostasis is very good with this.
And I haven't changed the settings.
You know, I mean, literally.
It is good.
Hemostasis is very good.
It is. It is good. And I haven't changed the settings. You have the option of controlling the hemostasis even better if you reduce the power and the frequency, but I didn't have to.
You always use a stabilizing, you know, so laser fiber is there, but
yeah, because I don't have a Kunz element. It's basically just the resectoscope with a very short channel at the tip, and is the resectoscope. I can't. The device that I have, you can do it with whatever, but this is the. And I also do this, very important. The bladder neck bleeders are the ones that are going to put you into problems. They are going to create problems. You see, I go around it, and sometimes I do it twice just to make sure that I coagulate. And I coagulate at the limit of the cut. Okay, you see that? At the very much of the limit over there. Sometimes I go in and come a bit out, so I see the mucosa of the bladder, and I just go around. Because whatever, and then I inflate the balloon with like 60 mils and keep it into the bladder. And it means that all bleeding, because what you're going to leave behind, if you have this view, there's no arterial bleeding. Everyone can agree. If you have this view, it is just venous bleeding inside but look how it looks. Inside the fossa where we took the prostate out. Venous bleeding will stop as long as you block the bladder neck with a balloon. I don't inflate the balloon in the fossa. I keep it in the bladder. But the bleeding from the bladder neck is the one that may cause me problems.
How much do you put in the catheter?
It depends on how big the prostate is. This was a small prostate, so probably I put like 40 mils. We took out like 55 grams in this procedure, so it's a small prostate. But if you take out 160 or 200 grams of prostate, then I usually put 70 mils, the maximum capacity of the balloon, and that's it. I've stopped here.
How long does it take? So time-wise, how long did it take you, Lorian?
How
long did it take you, time?
This procedure, it took me approximately 70 minutes with morcellation. But it was a small prostate. When we talk about larger prostate, it takes me longer.
Impressive operation and impressive laser.
It is a good compromise.
Very, very interesting. Yeah. The most modern laser now, this laser.
It is nice, yeah. Questions?
Very, very interesting.
Please.
For how many days you keeping your catheter after surgery?
Next morning off.
Next morning off.
One day.
It depends a lot on if I have a 250 gram prostate, and there will be larger bleeders, I may keep them longer. 23. We call it 23 hours. So it means so it's less than 24.
Like a 23.9.
Yeah.
Okay.
So next morning, that's the goal. Yeah.
Continuing the question, what do you think about the catheter-free?
Catheter-free HoLEP, it's doable. It is doable, but you have to be very good. You have to select your patients very well, because, these are not fit patients. We love to think about ourselves that, we are all fit, but we get to our 60s, 70s, and the muscles are not as they used to. So you have to be prudent and select your patients very well, but it is not something that you should not consider.
Okay, and what's about the laryngeal?
Yeah, that's a good question. I think to me, it was, I'm a kind of a HoLEP addicted surgeon. I really love it, but I love it that I think the learning curve never ends. I still find some cases very challenging. I still lose the plane. I still adapt and change the technique. I've done all the possible techniques. I can do whatever technique. it doesn't matter. I would recommend the same as my predecessor said, probably an incisional technique to start with, because it gives you landmarks. You know, I've cut this, I can unite this line with the other line. Learning curve, if someone tells you 50 cases and you'll be a master of HOLEP, probably that person is either, I don't know, I don't think it's an honest thing. 50 cases to understand where you are. I've got a mentor and a colleague who has done 5,000, and last month he changed his technique. So there's always room for improvement. Mini-lab, very good, but careful with morcellation. You don't have the same flow. So this is why we don't have, why don't we have 22 French resectoscopes? Have you ever asked, why don't we use a very small resectoscope to do a bladder tumor?
Коллеги, мы превышаем уже лимит. Thank you very much.
Thank you
very much. И переходим к следующей презентации. Биполярная энукуляция простаты. Мурат Юнусов, прошу.
Добрый день, коллеги. До меня выступали, конечно, представители богатых клиник. Теперь разрешите представить возможность...
Из очень богатой клиники.
Да.
Из очень богатой клиники.
Это больше, наверное, будет интересно тем, кто, возможно, не имеет таких лазеров различных видов, но хочет заниматься энукуляцией, особенно при больших аденомах. Здесь нам в помощь будет, конечно, биполярная энукуляция. Окей. Значит, вот наш больной с объемом 80 кубических сантиметров, ПСА в норме. 2 месяца у нас была установлена цистостома, и потом к нам пришел на энукуляцию, на операцию. Видите, мы проверяем здесь наши устья, все ли на месте. Это, так как имеется цистостома, некоторые изменения слизистой мочевого пузыря. Это кончик катетера. Принципы те же, то есть все энукуляционные техники различные, двухдолевая, однодолевая, то есть или единым блоком, не имеет значения, но мы тоже придерживаемся того принципа раннего отделения капсулы на уровне веромонтанум от наружного сфинктера. Вот таким подковообразный разрез. И я думаю, при биполярном наиболее четко мы можем видеть именно эту капсулу, потому что это она позволяет. И, как вы видите, разъединение, то есть попадание в этот слой между хирургической капсулой и аденомой здесь наиболее четко видна. Значит, эти движения используют только тубусом, производится только коагуляция открывающихся сосудов. И если такие вот моменты, здесь можно режим резания использовать. И как видите, четко видна капсула. То есть никуда мы как бы не отойдем, но вот это очень важный момент. Здесь тоже, как Фуркат Рауш сказал, такой кровавый аденома, но для биполярной энукуляции можно вот моментальную коагуляцию произвести без проблем. Максимально отделяем до того уровня, насколько позволяет, до шейки. И где наиболее легко идет, скажем, с какой доли, с правой доли, левой доли, нужно будет, мы так и продолжаем. Здесь наиболее анатомичное идет выделение, то есть энукуляция. Как видите, вот именно плоский такой слой, это у нас хирургическая капсула. Такое может создать впечатление, как будто мы проталкиваем вот этим петлей Хермана, но это так нельзя делать, мы это не проталкиваем, это толкает все-таки тубус, кончик тубуса, так как если мы будем сильно, то есть с большой, как говорится, энергией толкать, то мы легко можем сломать эту петлю. Поэтому используем только для резекции и коагуляции. Правая доля, вот как видите, легко отделяется. Моментальная коагуляция и отличная визуализация. То есть тех эффектов карбонизации и так далее здесь нет. И я думаю, те бюджетные клиники, где не имеют лазера, это, я думаю, наиболее оптимальный вариант. Если у них есть даже обычным коагуляционной петлей, можно производить инокуляцию. То есть стандартный набор для резектоскопии. Здесь мы продвигаемся на где-то 6 часах. Вот как видите, вот, это, здесь полоска слизистой. Здесь можно уже не бояться, что мы повредили сфинктер. Здесь тоже, вот видите. И можем просто его отсечь. То есть тех моментов, как недержание матча, здесь 100% можно не бояться, если вы правильно отделили от наружного сфинктера. Вот как видите, это только движение тубуса. Замечаете, вот параллельно идут сосуды на хирургической капсуле. И если это будет аденоматозная ткань, там совсем другое. Уже железистая ткань. Вот здесь, видите, на 12 часах, вот то, что остатки мы отделили, то есть слизистый и подслизистый. Здесь тоже проверяем, как идет. Если туго, то значит еще мы не в слою. Вот здесь уже, видите, да, вот параллельно идет сосуды. Это говорит о том, что мы в правильном слою. Можно переходить с одной доли на другую. И теми круговыми движениями постепенно отделяем. Можно выполнить, конечно, N-блок. Здесь решили чисто технически, когда есть ограничение движения тубуса, то можно и двухдолевой. Обычно мы делаем вот двухдолевое, вне зависимости, какая доля выражена, даже если выражена средняя доля. Вот видите, да, вот эти шварты, это все то, что держится за капсулу, то есть отделить. Это мы работаем где-то на 11 часах с переходом на другую долю. И вплоть до шейки. Так как аденома имеет такую грушевидную форму, надо, если придерживаться его анатомическому удалению, оно само, как говорится, приведет, но можно легко тоже, конечно, уйти в последствия. Вот мы уже полностью отделили. То есть никакого здесь, видите, повреждения или расслоения шейки нет. Здесь тоже вот такая техника сверху вниз. Видите, мы идем тоже, отделяем, уже инокулируем от шейки. Почему здесь важно дойти на этих, скажем, на 12 часах или на уровне 1 часа, тем самым мы освобождаем верхнюю часть, далее более тяжелее отделять снизу. И тогда есть сама аденома, или эта доля, она пролоббирует, уже выделяется в полость мочевого пузыря, и еще легче будет отделять. Здесь то есть, очень выраженные сосуды, но мы этого не боимся и спокойно можем коагулировать. И постоянно держать под контролем. Вот видите, это у нас сфинктер. Здесь все, нет никаких повреждений. Здесь вот сфинктер и доля правая. Также таким же способом постепенно инокулируем, отделяем. Ведь это в железе мы. Вот такими движениями можно, как говорится, протестить, в правильном направлении мы идем, в правильном слое или нет. Если нет, надо тогда глубже брать. Вот видите, да, она такую структуру имеет. Не всегда, она же не прямая, она, вот, инструмент прямой, а здесь нужно будет вот такими движениями. Вот, если нашли и этот слой, и дальше мы продвигаем его. Как при традиционной операции, если это делалось антеградно и производить пальцем, инокуляция и при открытой хирургии, да, здесь это ретроградно, но с помощью тубуса, вот этими проталкивающими движениями. Совершенно также бескровно, кровопотери минимальные, и здесь скорость высокая. Поэтому тоже в рутинной практике очень часто не холеб, а именно производим биполярную инокуляцию. Если будут какие-то остатки ткани аденоматозной, это не страшно, это можно потом протурить, немножко срезать. Но самое главное, не выходить за пределы хирургической капсулы. Как сказал профессор Драгош, там тоже как бы опытный ты не был. И в нашей практике случается, мы тоже выходим эти за пределы, потому что есть различные анатомии аденомы. Вот видите, здесь прекрасно видно, здесь параллельные сосуды. Видите, это капсула. Встречаются те, где мы уже инокулировали. Вот. Таким круговым движением мы проверяем. Параллельно постоянно идет. Здесь вот важный момент, это, смотрите, сейчас отделение от шейки. Мы очень большое внимание уделяем отделению от сфинктера. Шейка тоже немаловажная, так как, вы знаете, если мы, особенно при туре, срезаем это образование, делаем широким, и в дальнейшем мы, к сожалению, получаем осложнение в виде склероза шейки. Это тоже очень неприятное такое осложнение. Мы вот под аденомой, но немножко нам не дает инструменту двигаться, поэтому мы сейчас отделим, значит, разделим на две доли. Сверху у нас получается сейчас аденома, снизу шейка. Вот видите, да? Вот у нас. Вот здесь мы отделяем и уже безопасно можем соединить. То есть вот этот продольный разрез, и уже не бояться, что мы, как говорится, не что-то повредим подлежащее. Потому что снизу мы уже отделили. И вот таким движением можно вверх произвести резекцию, не бояться, что никаких там опасных таких структур, которые мы можем повредить, только аденоматозная ткань, да. Спереди у нас видна шейка, а это вот видите, она даже сама расслаивается. Если мы междолевое вот попадаем пространство, она тоже само разъединяется и производит наиболее бескровно. Это просто технически нам будет легче уже отделять, если мы это сделаем подолевое. Вот те же только слизистая, мы ее отделим. Вот и все. Вот здесь, вот видите, а потом уже это отделение, скажем, правое отдельно, и левая доля будет легко смещаться в правую сторону, и это технически и будет правильно. Вот видите, отделяем вот этими боковыми движениями, вот это у нас шейка. Видите, она, если мы вперед пойдем, мы можем расслоить и будем повреждать саму шейку. Небольшой разрез и контролируем вот этими движениями, мы четко можем уже видеть подлежащие структуры. Я думаю, это наиболее анатомичная будет инокуляция, и, соответственно, результаты будут даже, ну, нет у нас еще пока данных, но, думаю, на ретроградную, насколько эякуляция будет это влиять, если мы будем сохранять именно шейку. Видите, вот этими боковыми движениями видим капсулу. Видите, здесь немножко ушли, перфорация небольшая была. То есть здесь тоже надо будет осторожнее работать. Вот видите, да, вот такое у нас в виде грушевидной такой формы. Вот отделенная доля правая. Проверяем. Это уже заключительные этапы. Есть некоторые структуры, которые держат, мы их можем легко рассечь, а здесь производится коагуляция, вот и окончательное отделение.
Так, коллеги, вопросы
Всем.
какие есть к Дилмурору? Скажите, вам больше нравится энукляция или трансуретральная резекция?
В своей практике фактически 100% инокуляция.
Сейчас 100%.
Вне зависимости от размера, даже если...
Маленькие железы тоже.
Да, маленькие. Или делаем комбинируем. То есть первым этапом инокуляция до шейки и в дальнейшем бескровная резекция. Если немножко ленимся на марселяцию.
У вас пока лазерной инокуляции нет. У вас только пока биполярная инокуляция, да?
Да. Не, мы големые тоже инокуляция.
Големую инокуляцию.
Все есть.
Какие вопросы в аудитории?
Дильмурат Самихович, у вас после электроинокуляции кровотечения, ранние кровотечения были и недержание мочи?
Конечно, кровотечение случается, но из нашего опыта это, ну, наверное, на 100 кейсов один случай бывает. 1-2 бывает, конечно. По различным причинам. Я не думаю, это связано именно с инокуляцией или от техники, но какие-то нарушения сами больные. Что-то.
Как при любой электрохирургической операции.
Да, как и при...
Ничего нового. Та же энергия. Ну, конечно,
да,
и после лазера бывает.
По поводу недержания, тотального недержания не было, но, как и у вас в начале обучения, эти были, потому что ориентация точно нахождения вот этих структур всегда была сложно, поэтому, но сейчас я не боюсь, потому что я все уверенно могу сказать, что да, мы сохраним сфинктер, а бывают такие стрессовые, которые в течение 3 месяцев проходит. И пациенты довольны, то есть то качество жизни их удовлетворяет.
Спасибо большое за блестящую выполненную операцию. Мы немножечко превышаем, к сожалению, лимит, поэтому извините, пожалуйста, в отношении вопросов. Нам надо переходить к следующему, к круглому столу, который ведет Налиман Гаджиев. Сохранение континенции, эякуляции, миф или реальность после анатомической энукуляции. Пожалуйста.
Добрый день еще раз.
Ван Хамри, Виген Малхасян, на сцену, пожалуйста.
Дорогие друзья, действительно, можно часами смотреть за тем, как ребята скользят по плоскости. Действительно, очень несложно оказаться зависимым от эннуклеации. Но я на секундочку верну нас к камням. Помните, мы вчера проводили небольшой опрос. И давайте быстренько пробежимся по нему и вернемся к теме нашего круглого стола. Значит, какой тип ирригации мы используем? Обратите внимание, 45% используют ручные помпы. Какой-то небольшой процент, видимо, временно используют шприцы, чего бы, конечно, видеть не хотелось. Но, тем не менее, есть достаточно серьезная категория, это 53 ответа, 53 респондента, значит, которые используют машинную ирригацию. Это то, что вчера использовали мы. И вот Дильмурод так прибеднялся, что вот богатые клиники, у них есть действительно абсолютно все, включая и значит, ирригационные системы. Говоря о типе анестезии, ну, для меня было некоторым удивлением, посмотрите, половина респондентов, 65 ответов, практикуют гибкую хирургию под спинальной анестезией, что действительно, вот, по крайней мере, в нашей клинике это звучало бы достаточно удивительно. Помните, мы говорили про постпункционный люмбальный синдром, когда пациенты иногда вынуждены лежать очень долго. Значит, дальше смотрим. Готовите ли вы мочеточники перед гибкой хирургией? Обратите внимание, половина предстентирует и альфа-блокаторы. То есть, в принципе, этому уделяется значительное внимание, и это тоже не может не радовать. В отношении того, проверяете ли вы полуригидным уретероскопом мочеточник перед тем, как входить в почку, посмотрите, что да, всегда больше половины респондентов, что тоже в определенной степени вселяет оптимизм, и по большому счету вы можете рассмотреть изменения своей техники с использованием ультразвука во время индукции на операционном столе, в случае, если работаете с солитарными камнями. Ну и оцениваете ли вы мочеточник на выходе? Да, 100%. Но интересно ведь, ребят, и действительно вот такие ответы, они показывают достаточно высокий уровень урологии в Узбекистане, с чем я вас, собственно, и поздравляю. Теперь мы переходим к теме круглого стола. Действительно, вот мы любим, практикуем энуклеации, и несмотря на количество, тем не менее, каждый раз с замиранием сердца работаем в области сфинктера. Я скажу, у нас есть в России крупнейшие специалисты с огромным опытом, и, к счастью для нас, один из них сейчас сидит перед вами, нисколько не умаляя достоинств Евгения Андреевича Малхасяна, который прекрасно владеет этой техникой. Но, тем не менее, иногда вроде все прошло шикарно, а у пациента проблема. И вот мы сегодня поговорим о недержании мочи и сохранении эякуляции, потому что у пациентов сейчас информированность большая, все хотят сохранять свою сексуальную активность. Алексей Георгиевич, вот к первому вам вопрос. Как пионеру трансуретральной хирургии в России, без тени ложной скромности, вы действительно один из основателей, собственно, этого пласта хирургического. Вот на ваш взгляд, какие самые важные технические аспекты для сохранения удержания мочи?
Контролировать наружный сфинктер. Угу. Это стопроцентное, так сказать, обязательное выполнение. Угу. И крайне редко бывает удержание мочи, связанное с особенностями строения апикальной и неудаленной ткани. Угу. Крайне редко. Но я встречал подобных пациентов, когда она, вот эта вот образующаяся как бы висячая апикальная ткань, попадает в зону сфинктера, и он не окончательно не до конца смыкается. Но это крайне редко. Угу. Это очень хирургозависимое осложнение.
А что, по-вашему, есть неудержание мочи после операции? Будем ли мы относить недержание мочи, скажем, до 4-6 недель к осложнениям операции? Или это естественный ход вмешательства?
Неудержание – это не недержание.
Нет, мы сейчас говорим о недержании мочи.
Недержание мочи слишком большой срок, вы говорите, после операции. Недержание мочи все-таки очень четко коррелирует с травмой сфинктера. Угу. Очень четко. И недержание мочи из-за вегетативной симптоматики его не бывает. Это всегда неудержание. Нужно более правильно задавать вопросы пациенту, чтобы для себя определить, нарушен ли наружный сфинктер.
Спасибо, спасибо. Евгений Андреевич, скажите, пожалуйста, вот ваше отношение к раннему апикальному освобождению, очень раннему апикальному освобождению, то есть у нас сейчас появляется новый термин, very early apical release, и стандартное освобождение сфинктера?
Ну, соответственно, есть у нас пословица «береженного Бог бережет». Поэтому мы никогда, у нас нет опыта доведения, сознательного доведения пациента до недержания. Как только у нас появляется методика, которая, ну, по данным некоторых авторов, считается более оптимальной в данном конкретном случае, мы стараемся ее осваивать и придерживаться. Ну, в нашей клинике на сегодняшний день практикуется раннее освобождение сфинктера. Никогда не выполняется другая методика. Раннее, очень раннее освобождение сфинктера, но мы пока не перешли на эту методику.
Спасибо большое. Саид, we know that nowadays for younger patients, so staying sexually active is becoming a real concern. So what do you think? Is this goal quite achievable with anatomical endoscopic enucleation?
You mean keeping the sexuality?
Yeah, keeping the ejaculation, the antegrade ejaculation.
I think the part that keeps the ejaculation is the apical tissue. So I remember that I have attended in Cambridge with Tidahu, and he told me that he left some apical tissues to keep the ejaculation. The problem that it's not quite enough to have a good voiding. So have to sacrifice the ejaculation for the sake of good urination. And I believe that sexuality is important, but sometimes you are put into a situation that what the patient wants. He wants to urinate or he wants to ejaculate. If it's in between, we have to make an agreement. But I believe so that younger people, they need their ejaculation, and then after 5-10 years, you can provide them with another technique.
So, in other words, we cannot guarantee anything, even with ejaculator sparing techniques, is it?
Nothing except if you keep some apical tissue, which might affect the outcome of your operation.
Good. So let's imagine we have a 55-year-old patient with 90-gram adenoma, and he wants to stay active afterwards, I mean, in the ejaculation-wise. What would you suggest? Which technique? Which method?
It's, you mean 90 gram?
Yeah.
Okay, so he can, sometimes if he wants to do resume as a beginning, but the resume is above 80 gram. But I would suggest for him sparing, which is you keep the apical tissue, in the risk of having not a nice outcome. But he's 50, we have to give him the chance.
Good. So, Евгений Андреевич, ваше мнение? 90 грамм, 55 лет, хочет остаться активным после операции.
Я думаю, что, в принципе, мы бы предложили ему резюм, несмотря на вот это такое мнимое ограничение. И с большой долей вероятностью эта методика бы сработала. Здесь очень небольшое превышение этого условного cut-off line. И здесь, в принципе, я считаю, что пациент подходит под эту методику, если он настаивает, и приоритетом для него является сохранение именно эякуляции. Поскольку резюм на сегодняшний день, наверное, самый такой эффективный метод сохранения эякуляции.
Алексей Георгиевич, тот же самый вопрос. 55 лет, 90 грамм аденома, критично сохранить антеградную эякуляцию после операции.
Для меня, как человека с академическим образованием, недостаточно информации.
Ну, вот все, что есть. Вот оно уравнение, у нас очень мало времени.
Насколько обструктивен, это все имеет огромное значение. Огромное значение. Только потому, что у него 90 и 55 лет, вывод делать нельзя.
Ну, хорошо, я перефразирую вопрос. Значит, пациент идет на энуклеацию, анатомическую, эндоскопическую энуклеацию. Какую технику вы бы использовали для максимального сохранения эякуляторной способности?
Я в своих руках сделал бы ему транснатральную резекцию эякуляторно-протективную. Потому что эякуляторно-протективная энуклеация – это более сложный метод лечения.
Вы могли бы в двух словах для аудитории?
Могу. Значит, транснатральная резекция, как это было описано стандартно, обычно оставляют сантиметр, лучше 1,5 около семенного бугорка спереди от него. Да, шейка, поверьте мне, большого значения как бы не имеет. Это уже доказано. Энуклеация. Мы публиковали работу, в общем, с довольно неплохими результатами, сопоставимыми с транснатральной резекцией. Только у нас операция занимала на 1,5 часа, на час дольше. Мы удаляли, значит, ориентир шейко-мочевого пузыря. Все, что выступает над шейкой, мы удаляли. 5-7 часов инцизия и удаление составлением дорсальной части аденомы, не тронутой абсолютно, и удаляли боковые доли и вентральную ткань. Вот такая была у нас методика оккультурно-протективной энуклеации, но, опять же, технически она выполняется сложнее. Но она работает также реально 50 на 50.
Мы обсуждали этот вопрос с Филиппой, я думаю, все его знают. Это человек, который модифицировал халеб, предложил милеб с миниатюризированными инструментами. Его отношение к этому следующее, то есть действительно в сантиметре от холмика у нас эякуляторные мышцы, выполняется энуклеация, вылучивание, резекция средней долей только отступя сантиметр-полтора от холмика. Но и при этом, к сожалению, гарантировать мы ничего не можем.
50 на 50.
50 на 50. Ну, по разным данным, 60-70%, но это действительно очень близко к подброшенной монете. Таким образом, хочется сделать небольшое резюме. Во-первых, поблагодарить наших экспертов и сделать следующее резюме. При правильном выполнении и соблюдении техники, включая работу в слоях, выполнение раннего апикального освобождения, минимизации механического натяжения тканей аденомы во время энуклеации действительно способны минимизировать риск развития стойкого недержания мочи, которое сохраняется более 4-6 недель. Таким образом, с недержанием мочи как будто бы мы справились. И по разным данным, частота этого осложнения, она действительно варьирует, и обычно она меньше 1%. Говоря о сохранении эякуляторных способностей, действительно мы должны управлять ожиданиями пациента, не обещать ему лишнего. Действительно, пусть это будет 50 на 50, либо предлагать альтернативные методики, как предложил Саид Бенамри, Виген Андреевич Мухасян. Уверен, Алексей Георгиевич тоже поддерживает такой подход. Ну, мы его не рекламируем, поэтому спасибо вам огромное, ребят. Для меня было огромной честью быть с вами. Я уверен, что это наша не последняя встреча, и я приглашаю следующего спикера для продолжения конгресса. Спасибо.
Спасибо большое, Нариман Казиханович. У нас энуклеация простаты. Какой лазер для какой простаты? Уважаемый Винер Гаур. Лекция.
Thank you once again. I almost forgot I have a talk. Could I have my slides, please? Okay. So, we are coming to the last part of the meeting, but we are talking about a very important topic, which is enucleation. And I was just saying everybody is using different lasers, different techniques. This is, again, a topic which I really enjoy. We will skip some of these because we have already shown these. But the most important thing is if you're using bipolar enucleation or lasers, we will stick to the lasers because what we want to know is what do the experts say. We learned from Professor Peter, there's no expert. This presentation will also tell you the same thing. There is no expert. You are the expert, depending on how you use it. And some of my own practicals. So let's leave this, but if you have to look at enucleation, if you cannot do a surgery without all these factors considered, then that's not a complete surgery. So when we look at the sources of energy, then we start to think, what should we do? What is not acceptable today, even by guidelines, is you cannot do a resection of the prostate and call it enucleation. It should be a complete enucleation. And the evidence for that is strong. The guidelines also tell you there are two lasers to use. The diode laser, the thulium YAG laser, but if you look at the evidence, it is really weak. So these two lasers, in my opinion, were not to be considered until the new pulsed thulium YAG laser has come. We need to have better evidence that only Lorien can do a good job or can everybody do a good job. So we come back to what bipolar, which is the standard which many people consider. If you use this as your strong evidence, then first of all, enucleation with the laser is applicable for any prostate size, 30 to 80 ml and beyond. And then there are all those techniques and technologies which are available. The laser is the most versatile form because you have so many lasers and you can do it in different ways. So that's number one point to take home. The second thing, if you look at all the previous literature, it only tells you laser is good, but it does not tell you which laser is good, why is it good, and what exactly are you trying to achieve with laser. And that's the sad part about the guidelines, because they can't give you that evidence either. So, when you have all these options which are available, the two most important things, and some of it was discussed, is one, you cannot have permanent incontinence. You will have transient incontinence, but you cannot have permanent incontinence. There should be minimal change of erectile function, which is ejaculation or erection, because both are an outcome. Again, there's a controversy on which is ejaculation sparing enucleation, but we discussed it and I won't go into details, it's not part of this. So if you look at all the energy sources and you look at the evolution of it, it tells you one thing, it's never constant. It has to evolve, because every time a new laser is now made feasible, the concept changes. So we look at that and we decide which is the best energy source that I can use, because my hospital will tell me, buy one laser. And I will have to tell them, I don't know which is a good laser, and that's what we are here to discuss. Because if you look at it again, the last time we invented a laser was the Thuyak laser. It's come back in 2023. So with that, it was important for me to look at literature, because that's what I like to do. Because my hospital asked me this question when I started the Whole program, and I said, I don't know, let me look at literature. And this was not too long ago, it was just 3 years ago. Evidence shows that if you use laser power setting, even if you have the lowest power laser, you can do a whole up. But that does not mean that you can do a good whole up for big glands. That's number one. But if you start taking bigger glands, can we change the laser and get better? We looked at the analysis. Again, there is no answers. We even a network meta-analysis, which basically involves all the aspects of laser enucleation. We only know that the holmium laser, which is a gold standard, which most of us use, is good for long-term outcomes. That means post-void residual, IPSS, Qmax. This is a good outcome. The only thing which is not good is a green light laser, which is why the green light laser enucleation has fallen apart. Again, when we started looking at the different lasers for the technique, we also realized as the thulium fiber laser is coming in, it seems to be comparable. So you have two lasers, the holmium laser, the thulium laser. In the holmium laser, you have to have a high power holmium laser if you want to do bigger prostates. If you're doing small prostates, you don't need high power. That is the two take-home messages that we got from past analysis. So now we are wondering, can we use the thulium laser better than the holmium laser? No, it's the same, because it's ultimately the surgeon. The problem is the thulium laser or the thulium fiber laser, it has a little bit of a learning curve because the plane is rather not clean, because it causes a bit of charring. Now that has changed with the next generation of thulium fiber laser. Professor Alexei has shared his slide with me. It has an absolutely beautiful non-charring effect. So when you modulate the pulse, the companies are learning from what we tell them and improving the laser. At this point of time, today, it's still thulium fiber versus holmium. Thulium fiber has many different companies making different kinds of thulium fiber laser, and holmium laser has different companies making different pulses, different kinds of frequencies. And that's what's probably changing the game. So when we come back to lasers, does any particular laser perform better? Actually, we don't know. In the past. And this is all until the 2020, 2015. But what we do know is, if you want to do HOLEP, if you're not a good bipolar, if you don't know how to do bipolar enucleation, you will probably do a good laser enucleation. There is only one study which compared the learning curve of bipolar versus holmium, and they find that the juniors learn holmium much faster than bipolar enucleation. So we have a pulse modulated laser. Now we know there's holmium and thulium. We now come to the technique. So again, I insist, we only know that the holmium and the thulium fiber laser is good, which company you buy depending upon which company is available in your hospital. Now, how do I apply these two lasers to the technique? Because we know there's 2-lobe, 3-lobe, on-block, early apical release. There is no evidence in literature to tell you that answer. Like was mentioned in the morning, when you look at the meta-analysis, and if they cannot give you an answer, it's a waste of an effort. So we need to go back and start thinking, how do I change the whole way, and how do I really look at this? So I first got involved with the thulium fiber laser here. and I realized that this is not inferior. Then I said we have to reach out to all our friends and we should tell them, look, let's look at what you're doing. You are supposed to be experts. Can we get a better information? My own experience started off with the Moses fiber because that was what I had in my hospital. What I realized is it doesn't matter what technique I'm using, I am able to get an early trial of the catheter. Because the enucleation with a high power Moses laser or Moses-like laser, whether you use vapor tunnel or any other tunnel, you will get excellent hemostasis. If you have excellent hemostasis and you have done a good job and the capsule is intact, you can take off the catheter even as early as 4 hours. We'll come back to how that is useful later. But this was my first point, that in the holmium laser, I will definitely buy the Moses laser. When I started then looking at it a little more carefully, we realized in the guidelines, they also mentioned the one single thing: if you are using the laser, use the Moses laser, because it's good for coagulation. If it's good for coagulation, you can use it even on patients with antiplatelets and anticoagulants. You don't have to stop it. But this is only small evidence and a few RCDs. Then we started looking at the complications which came in, and we realized in the meta-analysis, bladder neck stenosis, there is no difference. If you look at incontinence and the technique of enucleation, there seems to be no difference in the laser technique, but they are not able to tell us which is a better technique to do. So I have a laser, I know how to do enucleation, I know what is important, but I don't know which technique to use. What's the point? So then we had to look at, or rather create new evidence, which is when I met Professor Herman, and I said, you are in the guidelines for 15 years. And you have not been able to tell us beyond the fact that laser is enucleation, is enucleation, is enucleation, Prof. Let's do something about it. We know each other well. He's very kind. He said, I don't have the time. Will you do something? So I said, okay, let's look at everything that there is in literature and try to get something. So we first created the registry, which was the first registry to document everybody who was doing laser enucleation at that point of time. Give your data. Let me look at it retrospectively and see what you have achieved. We had a good response. Even thank you, Professor Dilman, and thank you, Azim, and many people over here. First time we were able to now understand that both MOLEP and THULEP are equally same, whether you use 2-lobe, 3-lobe, or whichever technique, you have good outcomes with both. So that's number one. Whichever technique you use, both the lasers are good. We also realized if you look at the early. Now in HOLEP, please don't say delayed complications is 3 months. You need to look at a patient who's going to live for 10 years. You need to look at his complications 1 year later. You need to look at his outcomes 3 years later. That is late outcomes. Late outcomes wise, it seems to be that they are comparable. That means if you counsel your patient, I have a holmium laser, I have a thulium laser, you will have good outcomes even in the long term. If you start looking at the complications and functional outcomes, this is what literature tells you today. So this is the take home which you get from one outcome. Now when you look at every single technique which has been described, you suddenly get confused. I made this chart when I was learning and I said, everybody is doing HOLEP the way he wants to do it. Now HOLEP is meant to be in a certain way, so it's good. Surgeons are adapting the technique to whatever they would like because that's what they find. But they are still using HOLEP, they are still using TUFLEP. They are still using 2-lobe and 3-lobe and modifying that. So there is no answer which is better until now. When I made this chart, I said, no, I have to try to find an answer. And I have to try to find the answer for that glands which matters most. Because the small glands, you will leave behind some apical tissue. What happens with leaving behind apical tissue? He may void with a slightly lower Qmax. He may have ejaculation. He may have probably a slightly lower outcome because he's 55. At 75, he may grow back the prostate. But if you look at the big prostates, which typically may come usually from the age of 60 plus, then we realize that the thulium fiber laser with the en bloc has a shorter operative time because it is a better hemostatic laser. So if you look at the prostates which are bleeding, a thulium fiber laser for the bigger prostate seems to be promising. Now when this was studied, it was all retrospective until the Moses laser became available, the Quantas, a new fiber dust technology got available, and the vapor tunnels got available. So when we had that, we then started to again look back to see whether this correlates with what's available in literature. They now say the enucleation technique is more important than the laser fiber you use. So we've taken a swing back. Now, which enucleation technique? That they do not tell you. So we started looking at all the lasers now and started to see if I have to consider the two important things I showed you in the beginning. We didn't look at ejaculation because it was not available. People don't talk much about it. Then we realized that the TUFLEP is a good laser for 80 cc and above. And this is truly size independent because we now looked at the technique. We realized that you must do an early apical release. That is a common message. There are certain surgeons who prefer to do it later, but they still do an apical release. The common message is, if you release the apex, you don't stretch the sphincter, the incontinence is lesser. That's all. And doing an early apical release takes exactly 10 seconds, because that's the first thing that you do. You just cut the mucosa and you release the prostate. What we do find is when the prostate crosses the big prostate, which is 100 cc, if you use the early apical release, you have lesser complications. And this is because you are stretching the sphincter lesser and lesser, because as the prostate grows, we know it can grow outside, it can grow into the bladder, it will compress the urethra. So you do not want to stretch. Maybe in my hands, I know how to push the prostate. Maybe in somebody else's hand, they don't. So, but if you release it, you push it, no problem. You don't have stretching on the sphincter. That's important. So if at all you have to think, whichever laser you use, please use early apical release, especially if the prostate gets bigger. Number two, you will gain experience and then you will start realizing I am doing bigger and bigger and bigger prostates. Now we started looking at the prostates and started seeing, now created a registry and we said, let's look at the really big prostates, 80 cc and above. 80 cc, 200 cc, 300 cc, whatever you're doing. First thing, it's obvious, it's a bigger prostate, so longer enucleation time. But longer enucleation time in the non-en bloc. Why? Because when I release one lobe, I push it inside, I have to take hemostasis, go to the other side. When I finish the other side, I take hemostasis over there, then I come back to do the morcellation. Morcellation in big lasers is not easy. If I look at detailed, I realize morcellation is taking me more time than enucleation. So remember, if you're using en-bloc technique, you have only one lobe, one big thing inside. Maybe there's not enough space in the bladder. Maybe you want to put a suprapubic tube for irrigation. Maybe you want to come back another day to do morcellation if you spend 2 hours. Literature only tells you that en-bloc with early apical release is a better choice using either holmium, high power laser, or any thulium fiber laser. So these are the things that we learned so far. We then thought, if I look at the complications rate based on age, because we are doing prostate surgery generally for 70 and above or 80 and above. In Singapore, 80% of my patients are minimum 80 years of age. Then we realized in these people, because they don't have strong sphincters, as Lorian was saying, they don't have good muscles, they cannot be taught Kegel's exercise. You can do a enucleation, but these people will recover much slower, but they do not have permanent incontinence. So it is good to do HoLEP for them, even in the bigger glands, using en-bloc technique only with early apical release. Now, if you believe in two-lobe technique, sure, it's going to take you longer, that's all. But this is something which you must remember only if you have done an experience of 200 cases, you will get this outcome. That means it takes a long time for you to reach here. If you ask all the surgeons, and these surgeons are all super experts because they have done 4,000 to 5,000 cases. It is not me. I have not done so many cases, so I cannot. But these are people who are giving you the data, real-time data. Even the best of surgeons, I don't want to take names, were very upset when we published the paper because his rate of complication was high. But I said, now finally you have proof. And he changed his technique. Like Lorian said, it doesn't matter. 5,000, if you can change the technique and if you have the guts to change the technique, you're a good surgeon. But we finally have some evidence in literature which tells you what to do. I think the new lasers, the Tulio, I won't go into details, but it's similar. It's similar. I will, for the lack of time, skip that part. But I come back to Professor Alex's slide, which he gave to me. This is something super important to me. I would like to stay a little bit away from the plane to prevent the charring, but I don't want the charring to come in my histology because when you send it for histology, the prostate cancers are not well made out, and that's something you must remember in mind. So if you're thinking of a laser, think your pathologist also does not want you to spoil the laser specimen. And it gives you good effect. So carbonation is important. This is something, we're coming to the end, this is something which I learned in my personal experience, that as technology changes, if you upgrade and learn, 90% of the patients now get discharged in our hospital the same day. And this is from a surgeon who is not an expert. This is me. But the shortest time for ATCC is just 25 minutes because I don't worry about enucleation. I don't worry about coagulation. It allows me to teach my residents more peacefully because they are able to identify the plane better. And if you look at Moses 1 and Moses 2, which is there next to you, you'll see that it really opens up the plane beautifully. The laser fiber has less fiber burn back. I can use it for more cases, though in my country, the company says it's a single use. It also showed good economic value. This was verified. This is something which we learned, but it was verified by Professor Amy's publication and a very nice actual publication talking about doing this with trainees. So we were doing the right thing in our hospital. We also then realized this is a practical thing that I sleep peacefully. This is a WhatsApp message conversation I have with my colleague, what we call as the 23-hour HOLEP. I have stopped the irrigation 1.5 hours after that. There is no nurse changing the irrigation. Patient is absolutely perfect. And then I was happy. So I could now list more cases in my day-to-day practice because I didn't have bleeding as a worry. The nurses are not too worried. This allows you to develop a very good day surgery practice. And at the same time, the patient is perfectly all right, which is the most important thing. So if I have to summarize and take home the messages, I don't know which is a good technique in your hands, but I can tell you that literature points towards early apical release, en-bloc technique to be good with thulium fiber laser or the holmium laser. The company of the laser will sell itself, but it's the same lasers. They have just modified the pulse to sell it because they have to do that, but these are the two best power lasers. Okay, I think... yeah, this is a study which we are doing now. Thank you. I just wanted to thank everybody to participate in this study.
Thank you very much, Vineet. I think we're ready to take just one brief question from the audience, if there is one. So no questions. And my question is, so it's all about now the constant and never-ending battle of the holmium versus TFL. So as a person who analyzed tons of information, so to keep it simple, what's the score? Is it still drawn or is...
In the new holmium fiber lasers and the new thulium fiber lasers, it's equal.
It's equal.
Because you don't have carbonization. The effect of the pulse of the laser is very good with the holmium, is very good with the thulium. Both of them will give you equal coagulation. So if you look at coagulation, and if you look at that, they are the most important things for identifying the plane and bleeding. Both the lasers are good. Which is good in terms of outcomes, it's not the laser, it's you. It's you and me as a surgeon.
So getting back to the main question that asks your chief, which laser we should buy from the very beginning, so we can afford only one.
I will change my answer to my chief now and tell him which is the cheapest laser, which is easily maintainable in my hospital.
Should it be high power? Holmium?
It has to be high power.
High power.
If it is holmium, it has to be high power.
Okay.
If it is thulium fiber, it should be 60 watts and above.
Okay, thank you very much. So
thank you.
We move to next presentation.
We can go to online to Frederic Bantier. Is he online? Frederic?
Yes.
How are you? This is Said.
Good.
So you're going to talk to us about artificial intelligence in endourology. Go ahead.
Yeah, can you hear me properly?
Yes. Yes.
Perfect. So, and can you see my...
That slide is there. Yes. Go ahead.
Okay, good. So, to sincerely thank the organization and the committee for this invitation to speak about artificial intelligence in endourology. I would say that it's going to be the next hot topic within 5 years. We have to be aware of that. We have to implement that in our daily practice. So I'm really glad to give the opportunity to dive in today. So what we are going to do is here are my disclosures. I'm a consultant for Dornier MedTech. And first, this is where everything started. This Alan Turing Manifest, the imitation game. We all know the movie also, but the manifest is from 1950. And the idea was, how can we create an imitation of the human trying to solve a problem? And the main statement of this manifest that you can find online for free is, can machine think? And it's really important to get that, this idea of thinking and a machine. And when you look at the next and the two phases of the artificial intelligence in terms of modern artificial intelligence, you can find this guy, John McCarthy, who initiated with Marvin Minsky the notion of artificial intelligence in 1955. And those two guys stated that what was going to happen in their summer camp to create artificial intelligence. And the idea was every aspect of learning or any other feature of intelligence can then that the machine can be made to simulate it. You have the world language, form abstraction, and concepts solve kind of problems that is now reserved for humans and improve themselves. So you can see some words already in 1955 that we are going to use today. The idea of learning, the idea of a machine, the idea of simulation, using a language to treat some concepts and to get the improvement of the machine in time. And so this is Marvin Minsky, and he defined the last definition we have about artificial intelligence, and this is going to be the one we're going to stay with, and it's from 1968. It's the science of making machines do things that would require intelligence if done by man. And I think it's the best and most accurate definition that we can find about artificial intelligence. So when you're starting an artificial intelligence project, what do you need? You need to understand the concepts. You need to learn the language. You need to know how to train and improve the algorithm. You need to know that it's going to be a machine, and you need to get the best possible simulation of your machine. So you need all of that, and you see that those words are the same than the one than we found in 1955. So what fields do we have in artificial intelligence? We have machine learning, deep learning, natural language processing, and computer vision. And we're gonna detail a bit about these fields and concepts. In machine learning, you have supervised, unsupervised, reinforcement learning, and self-supervised learning. So four types of machine learning, and those types of machine learning are just not working the same way. Supervised learning, you give the inputs and the outputs to the algorithm, and it just finds the way and the rules to get the best output from the input data. Unsupervised is you give unlabeled data, and it will automatically define the rules. Reinforcement learning, you are gonna give him some clues. You're gonna give him the label, and you're gonna make the algorithm try something, make some errors, and by the reward or the penalties you're going to provide him with regarding to the errors or good answers he's going to provide you, you will be able to improve the algorithm and to fit the algorithm to get the best possible output. And the last one is a self-supervised learning. It's a bit like the unsupervised way to do machine learning. You get unlabeled data, and instead of defining rules, it will find surrogate tasks to get and to find a way to simplify the problem. Neural network is a bit different. The approach is we want to recreate what we have in the head, how is made our brain. This nest of all the neurons that we have, and we have something inputs, and we have like what is called the input layer, and you get the output layer. If you want to put an image, the input layer will not have the same number of neurons. If your output is a single label like O or 1, positive or negative from imaging data. So Neural networks is a bit different from machine learning because it tries to recreate the way your brain is really working. And this is the main aspect of deep learning, because you're going to see a lot in the literature, this word, this phrasing, deep learning, but deep learning is really different from machine learning. Computer vision, really completely in the mood of 2025. We are going to use a lot of neural networks for that, but some of them are going to be different. But the idea is you see a tomato, your eye see a tomato, converts the signal to your brain, that your brain is going to tell you that it's a tomato. But if you are going to see a tomato with a sensing device, the sensing device is going to find some features that the computer is going to interpret to give some proportions and probabilities to say that it's going to be maybe 84% chances to get this as a tomato. So you see the approach is completely different. Our brain is actually doing the summary and the probability summary of what you can see on the top of this slide. Then we have the natural language processing. This is very, very interesting because we know a lot about generative AI, but not a lot about understanding. But when you use, for example, ChatGPT, Mistral, all these large language models, you have to understand that first there is some text recognition, there is some text understanding and extraction of the words to get the best generation of a response. So we have to understand that natural language processing is both tasks, not only generation. And for generation, the most common one in neurology is EuroGPT, which is from Asia. And it's actually quite accurate in many languages. So you can use it whatever the country you're in. And it's quite accurate. I'm honestly using it and counseling to patients right now. Okay, so we have seen a bit the fields. Now we're going to see what you want to do. Do you want to classify, meaning that you have some fruits and you want to say, okay, is this a banana? Is this an apple or cherry? This is a classification task. Or do you want to do a regression task? Do you want to predict a duration, a volume, some diameter? Do you want the size of the fragments? This is a regression. You're going to predict a continuous variable. It's completely different. So you have classification and regression. And you have, for those two objectives, many ways to achieve that. So when you're going to read articles about it, be aware that first you need to understand the objective and then the way they've done the job. And there is multiple ways to do the same job and to have the same results and the same performances. So where can we apply AI in endourology in 2025? When you look at finding a literature review on any topic in endourology, you will always find a Bhaskar Somani paper. I've been told that it's actually accurate. And here's one. You will use AI in endourology for diagnosis, for outcomes prediction, for patient monitoring, or surgical planning. This is the four main fields for that. For diagnosis, this is maybe the best paper of last year, to my opinion, in terms of stone diagnosis. You can accurately get the size and the volume of a stone, a renal stone, using artificial intelligence. This was deep learning of automated kidney segmentation with a threshold of 130 Hounsfield units to get the good segmentation of the stone. And you can see that the DICE score, the similarity score, I would say, is really high. It's 0.9 and the maximum is 1. So it's actually super accurate. You can see that we can detect, we can quantify the stones now. And it's really helpful in our practice. What we need now is to infer it and to get it into our daily practice easily, meaning that if you need 1 hour to get that, it's not feasible with a patient just in front of you in clinic. Still in diagnosis, about UTUC and about endoscopic stone recognition, we know for a very long time that we can get from those images, from the scopes, we can predict some stone composition from the surface, from the section, and it's quite accurate, but it's not the same for every type of stone. The issue with that is that all stones could be mixed, and we have only 20% of pure stones in our practice, and still we don't see the same results for UTUC. Can we predict endoscopically if it's a low-grade or a high-grade tumor not working endoscopically? You can do it by pathomic on the analysis of the pathology, but still not easy to do endoscopically. About outcomes, you can predict the stone-free status after flexible uteroscopy. It's very interesting in this paper that you can see that when it's classification, this sort of a tree, which is called a random forest, is more or less the best one to predict classification outputs. So you can see that the accuracy is super high, 93%. And it's a multi-center, it was not the multi-center study, but we have the same results with the Flexor registry, which has been published recently. And you can see also the importance of the feature. You can see that the stone burden, meaning the volume or the diameter, was also very important to get to know the response about the stone-free status. It is reassuring that our human intelligence feeling is the same as the one found by the algorithm. If you can do it with success outcomes, we can do it with complications. You can see that some classifiers are very good, decision tree. And on the bottom of this slide, the CAT-Boost. CAT-Boost is a very famous classification algorithm. It's quite accurate in the last 2 years for many tasks. And you can see that, again, the accuracy in predicting the complications is over 90%. But how to choose? How to choose the best algo you want for the best task? Here is a clue. You can maybe use this guide. I would say that it's very complicated. I would not advise you to do an AI project if it's your first one alone. I would advise to get some engineer support for that. This is what we have in the lab in Paris. And honestly, after a few projects, you start to understand which algo is going to work, about the size of your data, about the type of objective you want, and the method you want to use. So how to choose is going to be where the magic happens, but still you need support to know really how to do it. This is something new. I'm presenting that for the first one. This is what I did when I was in London with Darren Smith. We used from more than 400 patients with acute renal colic, and we use the radiomix feature of the stone from the CT, and we can predict the spontaneous passage rate from this with a good AUC near 0.8 on the validation group. So it's now quite accurate, and I'm trying to use it. I've designed a small app for that. Just to give you the context, 1 year before going to do this fellowship in London, I have never used any type of coding. So now it's easier to code. It's not only for a small group of nerds, engineers in the lab. It's something that we can do as clinicians, so we can understand and we can try to do it. For instance, this app that I coded recently, it took me 1 day, 1 full day, and two afternoons. So it's not a big deal. For surgical planning, this is another example. You have some software that can give you the stone volume, and there is also this one who can give you and estimate the time of lithotripsy, the duration of lithotripsy according to the laser source, the laser fiber diameter, the type of stone, the energy, the pulse rate, and you get the estimated time of lithotripsy. In this case, it was 60 minutes. But this estimation is from in vitro ablation rates on stone phantoms. So it's in vitro, it's in the lab, where you can do everything when the fiber is purely in contact with the stone all along firing, while when you're in vivo, the stone is moving, the patient is breathing, you are not especially in a good mood, you are not especially the most experienced surgeon in the world, and you cannot say that all the pulses are going to the stone. So you cannot do, and you cannot compare the in vitro conditions to the in vivo conditions. So we try to create a reduction model of that. So it's regression. in terms of objective because we want to reduce a difference, which is a continuous variable. And from the close to 90% difference, now we are close to 4% difference, which is less than 4 minutes, 4 minutes out of 90 minutes of lithotripsy. So we can use those artificial intelligence algorithm and machine learning algorithm to reduce some kind of difference from the lab conditions to the in vivo conditions. Now, when you look at what large language models can do, you can see that it's able to detect and to classify some images and to recognize some patterns, some anatomy. You can see that it was very, very good in this publication to define where is the bladder neck, where is the bladder tumor, is there a cystitis or what. But you can also see that some other structures were very, very difficult to assimilate by the model. So we are going to open a new era in terms of face recognition in stone surgeries procedures or even robotic procedures, and we can use it for training, but also, we can also use it to create and to generate some operative reports. We can also use the large language models to get the type of stone, to get an automated interpretation, and to know how to adapt the diet after that. And you can see here, it was an easy picture from Professor Olivier Traxler about the calcium oxalate dehydrate, and it was very easily found by ChatGPT. So what about education? Do we still need to know and to learn about it? Honestly, yes. I think we need to be even more intelligent than the artificial intelligence, because we need to be an expert to drive the artificial intelligence and to still improve it. And we still need to know the complex cases. But to know the complex cases, we need to know the easy cases. What we need is to use this artificial intelligence to facilitate the curriculum of our residents to understand and to learn things. We don't need to be replaced as teachers by artificial intelligence, to my opinion, or it's just a fantasy in 2025 still. I told you a bit about patient information earlier in the presentation, and you can see here a very easy example. I told EuroGPT, as a patient, I have a 10 millimeter renal pelvic stone with low pain, and I've been told that flexible uteroscopy was the best option and it was mandatory. And I give the context that I wanted an answer in 10 lines. And you can see that the response is quite detailed. Flexible uteroscopy is a good option. It's minimally invasive, but it's not the only one. And there is some morbidity. So you have all the context. You have a good summary, but still, it's not completely replacing the surgeon. It may gonna identify some surgeons with push indications, I would say, but it's not gonna replace us yet. It's not here for that. This video, I've made it honestly for Bashkar Samani because I know he was very interested about that. We, in some countries, need to consent the patient using some videos. And I wanted to show you what I can do for that. So I provide some script with that, and you're going to see the results I got in 15 minutes. Okay, so you can see that this video took me 15 minutes to create, to generate, and edit. I just provide the link from a video on YouTube and provide a script that I also get from another large language models. So you see that it can really facilitate our daily practice also for that in preoperative period. So very, very important to get to know and to dive in those new tools that we have. The only thing that we don't really know is, can we use it really in our practice? Are we able to say that it's legal or not? Honestly, there is no much regulation. So if it's not illegal, we could say that it's legal. But you need to check with your institution if it's okay around ethics or not. After that, I will tell you that honestly, there is a lot, and a massive amount of models that have been developed and published in the literature, and I don't know much of them who's been really used in clinical practice, meaning how they're really inferred in our daily activity. And we need to embrace the idea of using AI for training, and it's going to be our next challenges at the EAU for sure. In conclusion, I would say that AI and Endourology, we're going to be very good friends and very close friends in the next years. And I hope that you like these presentations. Thank you for your attention.
So no questions for on this topic. So thank you, Frederick. It was outstanding presentation. Oh, wow, just one question. Please stay online.
Fred, many thanks. It's Lorian. Many thanks for joining us. You are very passionate about this subject, and we can call you a urologist expert in AI, though you deny it. It is very, very good to finish basically our Congress with your lecture, because it is a glimpse in the future. And you know what I did? I've asked ChatGPT. So ChatGPT, what's the future of the Central Asian Congress? And the response was, it was a very successful Congress, and there will be many more to come. So thanks a lot, my friend.
I would like to thank you all for this very kind invitation. I will hopefully be with you not only online, but in person for the next year, and especially to present the new hot topics about AI in endourology.
Thank you very much. Thank you very much. So, actually, following this topic, recently I received a meme and funny image where and the Sarah Connor from the famous movie Terminator on this image, nervously smoking, and the description says that this is how Sarah looks at you every time you use AI. So it's quite amazing how fast and rapidly growing this field, and we understand that they already do a lot better than us in some aspects, but I hope we'll still have some role in 10 years in urology as humans being. So I would like to invite our colleagues on the stage for the closing remarks. This session is closed.
Уважаемые коллеги, уважаемые наставники, уважаемые гости, по классике все хорошо, все хорошее когда-то начинается, поэтому у нас настал момент закрытия нашего, я думаю, надеюсь, что великолепного конгресса, поэтому я даю слово председателю попечительского совета Central Asian University Абджабор Абдивахиду. У него там представление нашего научного журнала. Абджаборике, мархамат.
Спасибо. Уважаемые дамы и господа, уважаемые друзья, я от имени попечительского совета университета Центральноазиатского и в том числе наших коллег на Аква Медлайн. Раз вас приветствовать вот на этом конгрессе. Вы знаете то, что университет молодой, и, собственно, вот и сама клиника тоже, по-моему, где-то 7 лет или 8 лет существует, да, по-моему, Азамджан? И за это время, я думаю, сложился очень сильный коллектив, в котором работают наши коллеги из-за рубежа. Университет поставил перед собой очень серьезные задачи. Я бы сказал, что это в первую очередь это политическая все-таки воля основателя этого университета, господина Артык Хаджаева Джахангира, который, собственно, сейчас вкладывает все свои усилия для того, чтобы реализовать ряд очень интересных проектов. Очень интересные проекты. Это создание, в общем-то, современного госпиталя вместе с университетской клиникой Кливленда, значит, с участием наших зарубежных партнеров, в том числе, значит, это все-таки развитие ряда, так сказать, вот тех направлений, которые связаны в первую очередь с медициной. Это идет в унисон с политической волей нашего президента Республики Узбекистан Шавката Мирзиёева. И я думаю, что, собственно, вот такого рода проведение конгрессов, вот как ваш конгресс, значит, для меня очень большая честь, в общем, участвовать с вами вместе на этом конгрессе. Этот конгресс – показатель того, что университет, в общем-то, вместе с клиникой Аква Медлайн ставит перед собой задачу развития такого важного сегмента для университетской деятельности, как наука, исследование, и как один из важных компонентов научных исследований – это издание журнала. Я думаю, что вы, собственно, на руках имеете этот журнал CAEC, значит, Journal of Applied Research. Значит, если обратили внимание, значит, все-таки в первую очередь это все-таки applied research, это прикладные исследования, которые позволяют нам, собственно, вместе с вами воспользоваться вашим опытом, вашими знаниями, результатами ваших исследований, в принципе, осуществить определенный трансфер методик, технологий в Узбекистан. И, собственно, я должен вам сказать, что это непростой журнал. Я думаю, что, собственно, в первую очередь, конечно, главный блок, значит, той исследовательской работы, он связан в первую очередь с медициной. Потому что медицина является все-таки в первую очередь главным приоритетом, значит, данного журнала, вообще данного университета во главе вот с господином Гулямовым Камроном, который руководит, значит, университетом. И должен вам сказать, что этот журнал будет выпускаться, в принципе, 4 раза в год, то есть это 4 издания в год, и у вас на руках сегодня находится первый номер этого журнала. У нас готов второй номер, у нас будет скоро и третий номер готов будет. Я думаю, что, собственно, если вы ознакомитесь, я вас призываю ознакомиться внимательно с содержанием этого журнала и приглашаю к сотрудничеству с нашей редакционной коллегией. Мы готовы публиковать, мы готовы, собственно, интересные материалы размещать, значит, в нашем журнале. Я думаю, что это в первую очередь, в общем-то, полезно будет не только нашим коллегам из центра, значит, из центров, специализированных центров Узбекистана, не только, значит, в общем-то, нашим клиникам в Узбекистане. Это будет интересно. Я думаю, что ознакомление с нашим опытом будет интересно и в том числе для наших зарубежных гостей. Значит, он абсолютно бесплатный. Он, в общем-то, предполагается, так сказать, быть распространяемым среди международных учреждений, представленных в Узбекистане. Он будет представлен в том числе для использования нашим партнерам, значит, не только за пределами, значит, Узбекистана, но и в том числе, в первую очередь, в Узбекистане. Если вы обратили внимание, значит, ряд статей, которые размещены в этом журнале, значит, они писались вместе со студентами. Для студентов нашего университета очень важный фактор, который мы принимаем во внимание, это вовлечение наших студентов непосредственно, значит, в исследовательские проекты. При этом я должен вам сказать, что исследовательские проекты – это один из самых главных приоритетов, значит, данного университета. Один очень важный момент, который нужно будет принять во внимание, значит, журнал исключительно, значит, все-таки не ограничен какими-то, так сказать, все-таки жесткими правилами. Значит, можно писать, можно публиковать, и я думаю, что, собственно, мы не ставим задачу, в принципе, в общем-то, значит, продвигать этот журнал для того, чтобы, собственно, сегодня на базе этого журнала защищались какие-то диссертации. Диссертации, пожалуйста, это не проблема, это будет осуществляться, но в первую очередь это площадка для того, чтобы, собственно, осуществлять обмен мнениями, видениями, обмен технологиями, главное, трансфер технологий в медицинской сфере, для того, чтобы служить, в первую очередь, нашему Отечеству, то есть нашей стране. Я хотел бы обратиться к нашим зарубежным партнерам, зарубежным участникам данного конгресса. Мне представляется сегодня то, что это все-таки один из первых шагов в осуществлении такого рода проектов. Мы нацелены на то, чтобы делать много разных конференций, конгрессов, симпозиумов. На днях у нас, в общем-то, будет проходить конференция по направлению туризм и гостеприимства, в котором будет участвовать 100 зарубежных наших партнеров. Значит, я думаю, что, собственно, это будет уже закреплено в качестве, так сказать, такой серьезной стратегии. For those who came from outside of Uzbekistan in order to share with all of your knowledge and skills you've created during your very interesting practice. First of all, let me express my deep respect and my gratitude on behalf of the Board of Trustees of the University, and express my thanks to those who have organized the very interesting Congress. And I hope and I wish that this kind of a congresses and this kind of a meetings with the exchange of the vision will be taking place over and over time in Uzbekistan. Once again, thank you very much, and especially for those who has organized, made it possible to organize this kind of a conference, the Congress in Uzbekistan in Tashkent. Thank you very much for your attention. Thanks.
The faculty and expert, the guests and the participants. When we finished our conference, I think we must give you some information about our conference. If you mind, I told about for Uzbek. Xana. Hurmatli fakultet rahbariyati, ekspertlar, mehmonlar, ishtirokchilar. Konferensiyamiz yakunlanishga kelib qoldi. Endi mana shu konferensiya yuzasidan qisqa bir ma'lumot bermoqchi edim. Mana shu konferensiyani uyushtirayotgan paytimizda mana shu ro'yxatdan o'tish kerak degan fikr bo'ldi. Va shu ro'yxatdan o'tgan ishtirokchilar soni 532 ta bo'lib chiqdi. Bundan tashqari onlayn masofadan turib ishtirok etuvchilar soni 112 ta. Demak, konferensiyamizda jami 650 ga yaqin mutaxassislar ishtirok etishdi. Endi bu zalimizda 500 ta o'rin qilinganida, mana bir o'tirishda qaraganimizda 438 ta o'rinlar to'la edi. Men aytmoqchimanki, zalimiz juda ham to'la va samarali ishlandi. Mana bu qatnashchilarimiz, fakultet, ya'ni ekspertlarimiz soni 26 ta. Demak, 26 ta deb hisoblaydigan bo'lsak, bular tomonidan amalga oshirilgan ish qarab chiqadigan bo'lsak, mana shu ishimizda 20 ta davlatdan ishtirokchilar qatnashdi. 2 ta jonli xirurgik amaliyot, ya'ni mahorat darsi o'tkazildi. 19 ta oldindan yozilgan mahorat darslari bugungi kunda eng zamonaviy texnologiyalarning ishtirokida qilingan ish bo'ldi. Va shu bilan birga 54 ta prezentatsiya va 6 ta debat bo'ldi. Men o'ylayman, bu o'z samarasini beradi va kelajakda bu narsani davom ettirishga zamin yaratadi. Kongressimiz yakunlashib, bir-birimizdan xayrlashamiz deb xayr deyish o'rniga men o'ylayman, uchrashguncha desak maqsadga muvofiq bo'ladi. Negaki kelajakda bu kongress davom etishida juda ham umidimiz katta. Shu bilan birga men O'zbekiston urologlar nomidan, O'zbekiston urologlar jamiyati nomidan kongressni uyushtirgan muassasaga shu bilan birga boshda juda ham mahorat bilan ishtirok etgan ekspertlarga minnatdorchilik bildirmoqchiman va ikkinchi so'zni Azimjon Nazirjonovga bermoqchiman.
Shuhrat Tursunovich, rahmat kattakon. Oxirgi so'z o'rnida demak ushbu kongressda demak devor ortida ko'rinmaydigan sahnada o'zini ishtiroki bilan aktiv qatnashgan butun jamoamizni shu yerga taklif qilmoqchi edim. Marhamat, bularga bitta qarsak chalib qo'yishlarini so'rardim. Nimaga deganda bu yerda hamma chiqinglar. Bu yerda taklif qilingan hozir ishtirok etgan xodimlarimiz 70 ga yaqin bu yerda jamoamiz ishtirok etdi va jamoamizning asosiy qismi bu o'sha Central Asian University, ya'ni o'sha studentimiz talabalari hisoblanadi. O'sha ya'ni bugungi kongressimizni veb-saytdan tortib hamma onlayn translyatsiya, barcha zapislar, barcha o'sha nima deydi, tashkiliy ishlarni ushbu talabalarimiz va o'sha jamoamiz amalga oshirdi. Bularsiz va albatta biz bilan birgalikda hamkorlikda aktiv ishtirok etgan, bizni taklif qilingan mutaxassislarimiz va undan tashqari O'zbekiston urologlar jamiyati va Respublika ixtisoslashtirilgan urologiya markazi xodimlariga ham o'z tashakkurimizni bildiramiz va yana bir bor bilan olqishlab qo'yishlarini so'ragan bo'lardim. Sizlarga kattakon rahmat va men o'ylaymanki, ushbu kongressdagi tajriba sizlar uchun kelajakda hali hayotda O'zbekistonimizni o'sha tibbiyotini rivojlanishi uchun o'sha qaysi sohada bo'lishingizdan qat'iy nazar sizlar uchun bir yaxshi bir tajriba bo'ldi deb o'ylayman va bundan keyin kongresslarda ham va bundan keyingi sizlarni oldinda turgan katta faoliyatingizda omad tilaymiz. Salomat bo'linglar, rahmat. Shu o'rinda barcha ishtirokchilarga Yevropa urologlar assotsiatsiyasi Endourology seksiyasi va shaxsan O'zbekiston urologlar jamiyati nomidan professor Olivier Traxerga va ushbu kongressimizda qatnashgan barcha chet ellik mutaxassislarimizga o'z tashakkurimizni bildiramiz. Ular o'zlarini bor mahoratlari, bor bilimlarini ishga soldilar deb o'ylayman va bundan tashqari o'sha O'rta Osiyodan va Rossiya Federatsiyasidan tashrif buyurgan va O'zbekiston Respublikasi nomidan ishtirok etgan barcha qatnashchilarga rahmat deyman va bu kongressimiz oxirgisi emas, Xudo xohlasa bu regular darajada o'tkaziladi va keyingi yilga yangi ma'lumotlarni kutib qolishingizni so'rayman. Hammangizga chuqur tashakkur bildiraman. Rahmat kattakon, sog' bo'linglar. Va oxirgi qisqacha e'lonimiz, demak, sertifikat, kongressda sertifikatimiz bor. Demak, bir hafta davomida o'sha sizlar registratsiya qilgan link orqali o'sha sertifikatlarni o'zingizlar sketchat qilib olsanglar bo'ladi. Rahmat e'tiboringlar uchun.
Ladies and gentlemen, thank you for being with us at the Central Asian Endourology Congress 2025. Your energy, ideas, and dedication made these 2 days truly remarkable. We wish you success and look forward to seeing you at future events.